All right, let's unpack this. Welcome to the Deep Dive, the show where we take a stack of dense, often complex information articles, research our own notes, and transform it into truly essential knowledge.
Yeah, basically your shortcut to being profoundly well-informed.
Exactly. Packed with surprising facts and, just enough context to keep you completely hooked. Our mission is always to cut through the noise and deliver those core, impactful insights you need to truly grasp a topic.
What's fascinating here is how we can distill incredibly intricate medical and scientific information, from the microscopic details of specific pathogens to the sweeping strategies of global health, and synthesize it into something not just understandable, but, well, actionable almost.
Right.
Our deep dive today is tailored for you, to arm you with a mastery-level understanding, as if you're already an elite professional in this demanding field. We're going to connect the dots in a way that helps you see the bigger picture and the tiny details that shape it.
Exactly. And today we're plunging headfirst into the challenging, often astonishing world of infectious diseases. We've got a rich collection of medical excerpts and cutting-edge research, and this journey promises to be quite a ride. We'll begin with a rare yet devastating brain infection caused by an amoeba you've probably never heard of.
Right.
Then we'll dive deep into the extensive, intricate world of malaria, a disease that has shaped human history, exploring its complex life cycle, its remarkable ability to adapt, and the ongoing global battle to control it.
And it is a battle.
Definitely. We'll finish with a quick, but equally insightful, look at another emerging tick-borne illness. Get ready for some truly surprising insights that will change how you think about these microscopic adversaries.
Yeah.
So let's kick things off with something that, while incredibly rare, is utterly compelling and shines a light on the hidden dangers that can exist right under our noses. We're talking about Plasmodium mandrillaris.
Right, a free-living amoeba.
Yeah, and it causes a devastating brain infection.
Yeah.
It's one of those pathogens that reminds you just how fragile life can be when faced with an unseen threat.
Indeed. Plasmodium mandrillaris is the specific culprit behind granulomatous amoebic encephalitis, or GAE. This isn't just any infection, it's a severe, often fatal inflammation of the brain.
Right.
Because it's so uncommon, its appearance is often profound, catching medical professionals off guard and really challenging their diagnostic prowess. Looking at the epidemiology of GAE, data from the California Encephalitis Project has pinpointed a few key risk factors. We seem to see it more frequently in younger individuals, in those with compromised immune systems, and somewhat unexpectedly among people of Hispanic ethnicity.
Okay.
The prevailing theory for how this amoeba takes hold is through exposure via the skin percutaneous, or maybe mucous membranes, like in the nose. Once it gains entry, it then spreads through the bloodstream, or hematogenously, to the brain and other vital organs, establishing a foothold where it can, well, wreak havoc.
And that particular spread pattern has a rather unsettling implication, doesn't it? It means there's a risk of transmission through organ transplantation.
Absolutely.
The sources reveal a couple of truly compelling and sobering examples from 2009 to 2010. Two clusters of Plasmodium infections were actually identified among transplant recipients because multiple people who received organs from the same donor developed these severe unexpected illnesses.
Wow.
And what makes it tricky is the incubation period, which ranged from about 17 to 24 days, giving the infection a substantial head start before symptoms even appeared.
What's especially striking about Plasmodium, setting it apart from many other opportunistic infections, is its frequent ability to affect individuals who are otherwise immunocompetent people with healthy immune systems.
Right. That is surprising.
For these individuals, the disease typically follows a subacute course, meaning it develops more gradually, not suddenly. Patients often present with telltale signs like focal neurologic symptoms, fevers, seizures, and persistent headaches. Tragically, in most cases, this insidious progression leads to death within a period ranging from just 1 week to several months after the initial onset of symptoms.
And the amoeba can leave visible clues too. The sources mention the possibility of external signs, with skin lesions appearing sometimes on the face, trunk, or extremities.
Yeah.
These can be a vital, though often late, diagnostic hint, pointing towards that internal struggle.
And beyond direct skin or mucous membrane contact, other routes of inoculation include inhaling contaminated dust, or maybe direct contact with the amoeba's trophozoites, that's the active feeding form,
Right.
or the cysts, which are the dormant forms found perhaps in stagnant water. This just highlights how pervasive and subtle the potential entry points for this dangerous pathogen can be in our environment. When it comes to diagnosing GAE, the initial steps usually involve examining the cerebrospinal fluid, or CSF, In the CSF, doctors often look for an increase in white blood cells, elevated protein levels, and glucose concentrations that are normal to slightly low. However, here's the critical diagnostic challenge. The amoebae themselves are rarely isolated directly from the CSF.
Oh.
This means clinicians are often relying on indirect markers, which makes a definitive diagnosis much, much harder.
So, if the amoeba is so hard to spot in the CSS, how do doctors get closer to a diagnosis? Imaging studies become incredibly important then.
Exactly. A brain MRI, for instance, often reveals multiple areas of damage, what are called hypodense lesions.
Right.
Typically, you might see a large lesion in one area, like the parieto-occipital lobe, along with other smaller, scattered lesions throughout the brain. While these findings are highly suggestive, they don't definitively point to balamuthia on their own, you see, precisely. For a definitive diagnosis, specialized tools become absolutely essential. The Centers for Disease Control and Prevention, the CDC, offers specific diagnostic assays, including fluorescent antibody tests and PCR assays.
Ah, the molecular methods.
Yes. These molecular methods are much more targeted and can directly identify the amoeba's genetic material, confirming the diagnosis where clinical signs and initial lab tests might, well, fall short.
And when considering what else it could be, the differential diagnosis isn't straightforward, I imagine. Clinicians might initially suspect other serious neurological conditions, like tuberculomas, those masses caused by tuberculosis,
Right.
or neurocysticercosis, which is a parasitic infection caused by tapeworm larvae. This really underscores the diagnostic complexity and the need for those highly specific tests.
In terms of treatment and prognosis, the situation is unfortunately quite challenging. The sources note that the handful of surviving patients in the United States were treated with a range of drugs, including things like pentamidine, flucytosine, sulfadiazine, and macrolides.
A real cocktail approach.
Exactly. This multi-drug approach highlights the kind of experimental nature of treatment, as there isn't a single universally effective drug. The rarity of the disease just means established treatment protocols are incredibly difficult to develop.
But medical knowledge is always evolving, right? Even for rare diseases. The CDC has recently updated its recommendations to include miltefosine in the treatment regimen for GAE.
That's correct.
This drug is also used for treating other free-living amoebae, so it represents a step forward and offers a new potential therapeutic approach for this devastating infection.
Despite these therapeutic efforts, it's crucial to emphasize the profound severity of GAE. This is a rare but exceptionally deadly infection, and treatment remains incredibly difficult. It truly stands as one of those unseen threats that demands specialized expertise and a swift, coordinated response when it does emerge.
Okay, moving from a rare, devastating brain infection to one that has plagued humanity for literally millennia, let's turn our attention to malaria.
A huge topic.
William Osler, a renowned physician from 1896, famously captured its historical grip on us when he said, and I quote, "Humanity has but three great enemies: fever, famine, and war. Of these, by far the greatest, by far the most terrible, is fever."
Powerful words.
And for an enormous span of human history, malaria was arguably the dominant cause of that terrible fever globally.
At its core, malaria is a protozoan disease. It's caused by tiny single-celled parasites, but it's transmitted by something much larger: the bite of an infected female Anopheles mosquito.
Right.
This seemingly simple mode of transmission belies an immense and complex global impact, making malaria one of the most significant parasitic diseases affecting humans.
And when we talk about immense global impact, the numbers are truly staggering. Our sources tell us malaria is still transmitted in 87 countries, affecting a mind-boggling 3 billion people.
3 billion.
In 2019 alone, there were an estimated 229 million cases and a heartbreaking 409,000 deaths. To put that in perspective, that's approximately 1,100 people dying from malaria every single day. Just pause for a moment and consider that scale of suffering and loss.
What's fascinating here is the roller coaster trajectory of control efforts. Between 2000 and 2015, there was a dramatic global decrease in malaria mortality rates, a testament to the highly effective control programs that were implemented worldwide.
Right, some real progress.
But since 2015, we've sadly seen a troubling reversal. Progress has stalled, and estimated global case numbers have been steadily rising again. This represents a significant and, frankly, disheartening setback for global health initiatives.
It's a surprising contrast. Malaria was actually eliminated from countries like the United States, Canada, Europe, and Russia more than 50 years ago. Yet, between 1970 and 2000, its prevalence saw a resurgence in many parts of the tropics. This resurgence spurred a substantial global response with significant investment aimed at increasing access to accurate diagnosis, effective treatments, and the widespread distribution of insecticide-treated bed nets.
Indeed. Bolstered by these investments, an increasing number of countries that previously had low malaria transmission are now pursuing the incredibly ambitious goal of malaria elimination.
Right.
However, this critical goal faces formidable threats. The increasing resistance of Plasmodium parasites to anti-malarial drugs and growing resistance in the Anopheles mosquito vectors to the very insecticides designed to control them. It's a two-front war, really.
So even with all the scientific advancements and decades of global effort, malaria remains an incredibly heavy burden on tropical communities, a constant threat to non-endemic countries, and a real danger to travelers. It is as formidable an opponent today as it has been for centuries. The battle is far from over, and it's constantly evolving. Let's truly dive deep now into what makes malaria tick, or perhaps more accurately, what makes the parasite replicate. The illness is caused by organisms from the genus Plasmodium. Right. And while there are many species in this genus, 6 main ones are responsible for nearly all human malarial infections. These are P. falciparum, P. vivax, 2 morphologically identical but genetically distinct species of P. ovale curtici and Wallacari.
Yes, that's a relatively recent distinction.
P. malaria, and in Southeast Asia, the monkey malaria parasite, P. knowlesi, which is increasingly recognized as a cause of human disease.
It's also worth noting that occasionally humans can be infected with other monkey parasites like P. simium in South America or P. cynomolgi in Southeast Asia. This highlights the fluidity of pathogen spillover. The severity landscape is crucial here. Almost all malaria deaths are attributed to P. falciparum due to its unique and dangerous pathology. However, P. knowlesi and P. vivax are also very capable of causing severe illness, a point often underestimated in the shadow of falciparum. The incredibly complex life cycle of the malaria parasite in humans kicks off with a mosquito bite. Imagine an infected female Anopheles mosquito taking a blood meal. From her salivary glands, she injects microscopic motile plasmodial sporozoites directly into your bloodstream.
Tiny invaders?
Exactly. These tiny invaders are then rapidly carried via the bloodstream straight to the liver, where the first crucial stage of human infection begins.
Once in the liver, these sporozoites don't waste any time. They quickly invade the liver cells, hepatic parenchymal cells, and begin a period of asexual reproduction, a process called intrahepatic or preerythrocytic schizogony.
Right, silent phase.
Yes, and this is an absolutely incredible amplification stage. A single sporozoid can multiply into a massive number of daughter merozoites, from 10,000 to over 30,000.
It's staggering multiplication.
For instance, P. falciparum can release up to 30,000 merozoites per infected liver cell, while P. vivax typically releases around 10,000. It's a silent, explosive multiplication that primes the body for disease.
What's truly unique and problematic about P. vivax and P. ovale infections is that a proportion of these intrahepatic forms don't immediately develop and burst from the liver.
Right, they hang back.
Exactly. Instead, they remain inert or dormant for a period that can range from 2 weeks to over a year. These silent hidden forms are called hypnozoites.
Hypnozoites.
And they are the root cause of the vexing relapses that characterize infections with these particular species, making eradication so much harder.
After this liver stage, the newly formed merozoites are released into the bloodstream and immediately invade red blood cells, or RBCs, transforming into what are called trophozoites.
And this is where the trouble really starts for the host.
Yes. This is where the rapid multiplication truly begins in the bloodstream, expanding 6 to 20-fold every 48 hours for most species. But it's even faster for P. knowlesi, which multiplies every 24 hours, truly dangerous acceleration, and a bit slower for P. malariae at every 72 hours.
That 24-hour cycle for knowlesi is why it can become severe so quickly.
Makes sense. And here's a key point that tells you when symptoms might begin. They typically start to manifest when parasite densities reach approximately 50 parasites per microliter of blood, which astonishingly translates to about 100 million parasites in an adult's entire body.
As the parasite develops and grows within an infected red blood cell, it causes significant changes. The parasite consumes and degrades hemoglobin, the protein responsible for oxygen transport.
Is the iron, right?
Essentially, yes, the protein components. Crucially, it has to detoxify the potentially harmful byproduct of this process, heme, by crystallizing it into inert hemozoin, what's often called malaria pigment.
The pigment.
Yes. This internal change isn't the only one. The infected red blood cell itself becomes more irregular in shape, more antigenic to the host immune system, and notably less deformable. These physical changes are absolutely central to how the disease causes so much damage, especially in the microcirculation. When viewed under a microscope, these morphological changes are vital for accurate diagnosis and differentiating species. In their early stages of red blood cell development, the small ring forms of different malaria species appear quite similar.
Tricky at first.
Very. However, as the trophozoates and large, distinct species-specific characteristics become evident, you can start to see the malaria pigment, and the parasite often takes on an irregular or amoeboid shape. By the end of this red blood cell cycle, the parasite, now called a schizont, has consumed about 2/3 of the RBC's hemoglobin and occupies most of the cell, having undergone multiple nuclear divisions.
Then, boom. The infected red blood cell ruptures, releasing anywhere from 6 to 30 daughter merozoids ready to invade new RBCs. Each of these new merozoids is capable of invading a fresh red blood cell, thus repeating the cycle and relentlessly amplifying the infection within the human host. It's truly a relentless, explosive process within your own blood.
So, to summarize the human phase pathology, the clinical disease you see, the symptoms, the fever, the organ damage, is primarily caused by the direct effects of these asexual parasites. Their invasion, growth, and destruction of red blood cells, coupled with the host's subsequent, often damaging immune reaction to this ongoing assault. The parasite's life cycle within the human host doesn't end with just asexual reproduction, which causes the disease. A fascinating switch occurs. Some of the blood stage parasites develop into morphologically distinct, longer-lived sexual forms known as gametocytes.
The transmission stage.
Precisely. These are the forms that are essential for transmission back to the mosquito, completing the cycle. In falciparum malaria, this switch to gametocytogenesis is typically delayed by several asexual cycles. Interestingly, female gametocytes usually outnumber males by a ratio of about 4.1, perhaps optimizing for successful fertilization in the mosquito gut.
And this brings us back to the mosquito's absolutely vital role in completing the cycle. When a female Anopheles mosquito ingests these gametocytes during a blood meal, a remarkable transformation begins.
It's incredible biology.
In the mosquito's midgut, the male gametocyte rapidly exflagellates, essentially bursting forth into 8 tiny motile male gametes. These then furiously seek out and fuse with the female gametocytes undergoing sexual division meiosis to form a zygote.
This zygote then matures into an eukaryote, which is a motile invasive form that can move purposefully. The eukaryote penetrates and insists in the mosquito's gut wall, forming what's called an oocyst.
Okay.
This oocyst then grows through asexual division, multiplying until it bursts, liberating countless motile sporozoites. These sporozoites, the very first stage we discussed, then migrate through the mosquito's circulatory fluid, the hemolymph, to its salivary glands, ready to be inoculated into another unsuspecting human during the mosquito's next blood meal, thus completing this incredibly intricate and precisely timed life cycle. It's a masterclass in parasitic survival.
Now, let's take an even deeper dive into the exquisite specificity of these parasites when it comes to picking their red blood cells and attaching to them. It's not just any red blood cell that will do. There's a highly selective molecular process at play that varies by species.
Precisely. P. falciparum shows a preference for younger red blood cells, but critically, it has the dangerous ability to invade red blood cells of all ages.
That's key.
It is. This broader tropism contributes significantly to its capacity for generating extremely high parasite densities and consequently causing severe disease. In contrast, P. vivax and P. ovale have a marked predilection for reticulocytes and young red blood cells, specifically those up to 2 weeks old.
More picky.
You could say that. P. malariae, on the other hand, prefers older, more mature cells, and P. knowlesi also shows a preference for younger cells, similar to falciparum.
And the mechanism by which these merozoids actually attach to and then invade erythrocytes is an incredibly intricate molecular dance involving specific proteins and receptors.
Yes, it truly is a sophisticated interaction. For P. falciparum merozoites, they utilize a variety of binding proteins, like erythrocyte-binding antigen 175, EBA 175, and EBL 140, to connect with specific molecules on the red cell surface, primarily glycophorins A and C.
Glycophorins, okay.
Glycophorins B and D also play supporting roles. But a crucial, perhaps the critical interaction involves the merozoite reticulocyte binding protein homolog 5, known as PFRH5.
PFRH5.
PFRH5, yes. It binds to a red cell receptor called basogen, also known as CD147 or M-L-enzyme. This is a very specific and essential step for P. falciparum to successfully invade the red blood cell.
So it's not just about getting into any red blood cell. It's about targeting specific molecular locks on the cell surface with their own molecular keys.
Exactly, and the specificity is even more pronounced with P. vivax. It specifically binds to receptors found on developing red blood cells. The Duffy blood group antigen, specifically FIA or FIB, plays an incredibly important role in its invasion.
Ah, the Duffy antigen connection.
Precisely. This explains a critical epidemiological and genetic fact. Most West Africans and individuals with origins in that region possess the Duffy negative 5-5 phenotype. This genetic trait renders them generally resistant to P. vivax malaria, providing a fascinating natural protection against this particular species.
Wow.
It's also noted that P. nalisi also preferentially invades Duffy-positive human red blood cells, highlighting a shared susceptibility mechanism based on this blood group.
Let's zoom out now to the broader picture.
Yeah.
The epidemiology of malaria. This is where we understand its global footprint, how it spreads, and why it affects different regions and populations in unique ways. Malaria, as we know, is found throughout most of the tropical and subtropical regions of the world.
And within these vast tropical regions, the predominant Plasmodium species varies significantly, influencing the disease burden and control strategies. P. falciparum, the deadliest form, is most common in Africa, New Guinea, and Hispaniola, which includes the Dominican Republic and Haiti. P. vivax, on the other hand, is prevalent in the Horn of Africa and Mauritania, across South America and throughout Southeast Asia. Its prevalence is roughly equal to that of P. falciparum on the Indian subcontinent and in Oceania.
So clearly it's not a one-size-fits-all situation.
Yeah.
P. malaria is found in most endemic areas, especially across sub-Saharan Africa, but it's considerably less common than falciparum or vivax. And P. oval is relatively unusual outside of Africa, typically making up less than 1% of the total isolates where it is found.
Lastly, P. nalisi, the monkey malaria parasite we mentioned earlier, commonly causes human infections on the island of Borneo and, to a lesser extent, in other parts of Southeast Asia, specifically where its main hosts, the long-tailed and pig-tailed macaques, are found. The key takeaway here is that malaria epidemiology is incredibly complex, with considerable variation in prevalence, species, and transmission intensity, even within relatively small geographic areas. Understanding these local nuances is critical for effective control. Traditionally, the intensity of malaria transmission, or its endemicity, has been classified using a few key terms, often based on rates of microscopy-detected parasitemia or palpable spleens in children aged 2 to 9 years.
Okay, the classifications.
Right. We talk about 4 levels. Hypoendemic, where prevalence is less than 10%. Mesoendemic, ranging from 11% to 50%. Hyperendemic, between 51% and 75%. And holoendemic, where prevalence is greater than 75%. This classification helps public health officials understand the baseline intensity of transmission and the expected level of community immunity.
And these classifications directly inform our understanding of transmission patterns. In hollow and hyperendemic areas like much of tropical Africa or coastal New Guinea, where P. falciparum transmission is constant and intense, we see what's called stable transmission.
Stable.
People in these regions may sustain 1 or more infectious mosquito bites per week, and they are repeatedly infected throughout their lives. It's a continuous exposure.
The consequence of the stable, intense transmission is significant malaria morbidity and mortality, particularly during early childhood, before immunity has had a chance to develop. However, if a child survives these repeated infections, they gradually acquire a hard-won immunity against severe disease. As they get older, their infections become increasingly likely to be asymptomatic, meaning they carry the parasite but don't show symptoms. These asymptomatic older children and adults then become a major, often hidden source of malaria transmission within the community, perpetuating the cycle.
But the situation isn't static. As malaria control measures advance and urbanization expands, environmental conditions can become less conducive to such intense transmission. In these scenarios, entire populations across all age groups may actually lose their protective immunity and become susceptible to symptomatic illness again. This loss of herd immunity can create new vulnerabilities.
This stands in stark contrast to unstable transmission, which characterizes hypoendemic areas. Here, transmission is low, erratic, or highly focal, preventing populations from acquiring widespread protective immunity.
Right, less consistent exposure.
Exactly. So symptomatic disease can occur across all age groups, not just children, because no one has built up a strong defense.
We also see clear seasonal variations, even in stable transmission areas. There's often a marked increase in symptomatic malaria during the rainy season.
Absolutely, the mosquito season.
Right. This directly coincides with increased mosquito breeding and, consequently, increased transmission, as more mosquitoes mean more opportunities for the parasite to spread.
Furthermore, malaria can behave like an epidemic disease, particularly in unstable malaria areas. Hotspots for this include northern India, parts of the Horn of Africa, Rwanda, Burundi, southern Africa, and Madagascar. Epidemics can be triggered by critical changes in environmental, economic, or social conditions. For example, heavy rains following a drought can create ideal mosquito breeding grounds, or the migration of refugees or workers from non-malarious regions to endemic areas can introduce a susceptible population to the parasite. Even a breakdown in malaria control services due to war or civil disorder, such as the recent resurgence seen in Venezuela due to ongoing crises, can fuel these devastating outbreaks.
Right, infrastructure breakdown is key.
It is. These epidemics are particularly dangerous because they often result in high mortality rates across all age groups, precisely because widespread immunity isn't present. The principal factors determining malaria epidemiology are primarily dictated by the mosquito vectors themselves. Specifically, their density, their human biting habits, and crucially, their longevity.
Longevity seems really important.
It's critical. While over 100 of the more than 400 Anopheles species can transmit malaria, only about 40 commonly do so, and their efficiency as vectors varies enormously.
It's a remarkably precise quantitative relationship, actually. The intensity of malaria transmission is directly proportional to the density of the mosquito vector, but then it's proportional to the square of the number of human bites per day per mosquito.
The square, yeah.
And, astonishingly, it's proportional to the 10th power of the probability of the mosquitoes surviving for just one day. This highlights how incredibly important mosquito longevity is to the entire transmission cycle.
That exponential relationship underscores a critical biological requirement. The parasite's life cycle within the mosquito, known as sporogony, takes anywhere from 8 to 30 days, depending on the ambient temperature.
Okay.
This means for a mosquito to be capable of transmitting malaria, it must survive for more than 7 days, which is longer than many mosquitoes typically live. If it dies before then, the parasite cannot complete its development and cannot be passed on to another human.
Temperature also plays a key role, setting geographic limits. Sporogony isn't completed at cooler temperatures below 16 degrees C for P. vivax and 21 degrees C for P. falciparum.
Right, needs warmth.
This explains why transmission generally doesn't occur below these temperatures or at high altitudes. Though surprisingly, outbreaks have occurred in previously malaria-free highlands of eastern Africa above 1,500 meters, demonstrating the adaptability of both parasite and vector, and the constant threat of expansion.
The most effective mosquito vectors are those that are long-lived, occur in high densities in tropical climates, breed readily, and critically prefer to bite humans over other animals.
Human-focused vectors.
Exactly. A prime example is the Anopheles gambiae species complex in Africa, which checks all these boxes. A common measure of malaria transmission in an area is the entomologic inoculation rate. That is, the number of sporozoite-positive mosquito bites a person receives per year. The EIR, yes. This rate varies dramatically, from less than 1 in parts of Latin America and Southeast Asia to over 300 in some areas of tropical Africa, truly painting a picture of the diverse transmission intensities and the challenge of control. Once a malaria parasite successfully invades a red blood cell, the impact on that cell is immediate and progressive. The growing parasite rapidly consumes and degrades the intracellular proteins, principally hemoglobin.
Gotta eat.
Right. A crucial part of this process involves the detoxification of potentially toxic hemog, a byproduct of hemoglobin degradation. The parasite cleverly manages this by lipid-mediated crystallization into biologically inert hemozoin, often called malaria pigment.
We mentioned that pigment earlier.
Yes. Beyond this internal change, the infected red blood cell itself undergoes significant alterations. It becomes more irregular in shape, more antigenic to the host immune system, and notably, less deformable. These changes are absolutely central to how the disease causes so much damage, especially in the body's microcirculation.
And this brings us to a unique and incredibly dangerous mechanism specific to P. falciparum infections. About 12 to 15 hours after invading a red blood cell, the parasite triggers the formation of membrane protuberances called knobs on the erythrocyte surface.
Knobs.
These knobs then extrude a crucial protein, a high molecular weight, antigenically variant, strain-specific erythrocyte membrane adhesive protein known as PFEMP1. Think of this PFEMP1 as the parasite's secret grappling hook.
Exactly. This PFEMP1 protein mediates a process called cytoadherence, allowing the infected red blood cells to stick to receptors on the delicate lining of small blood vessels, the venular and capillary endothelium in vital organs.
Sticking where they shouldn't.
Precisely. Several specific vascular receptors have been identified as crucial in this process. Intracellular adhesion molecule 1, ICMM1, and endothelial protein C receptor, EPCR, are particularly important in the brain, contributing to cerebral malaria. Chondroitin sulfate B predominates as a binding site in the placenta, explaining why pregnant women are so vulnerable. And CD36 binds parasitized red blood cells in most other organs.
And it doesn't stop there. These infected red blood cells may also adhere to uninfected red blood cells, forming what are called rosettes, or even clump together with other parasitized red blood cells, a process known as agglutination.
Creating little traffic jams.
Basically.
Oh.
These interconnected processes, cytoadherence, rosetting, and agglutination, are absolutely central to the severe pathology of P. falciparum malaria.
The critical outcome of these adhesion processes is the sequestration of infected red blood cells in vital organs, most notably the brain, but also the kidneys, lungs, and placenta. By sticking to the vessel lining, they essentially block or interfere with normal microcirculatory blood flow and metabolism, leading to organ dysfunction and failure. And what's particularly insidious from the parasite's perspective is that these sequestered parasites continue to develop and multiply safely out of reach of the host's principal defense mechanism. Splenic processing and filtration, which would normally remove damaged red blood cells.
Hiding from the spleen.
Exactly. As a direct consequence, in P. falciparum malaria, only the younger, early ring forms of the asexual parasites typically circulate in the peripheral blood. This means that the level of peripheral parasitemia, the parasite count in a routine blood smear, can significantly underestimate the true, much higher number of parasites hidden within the body, making diagnosis and assessment of severity much more challenging.
And it's not just the infected cells that are compromised. In severe malaria, even the uninfected red blood cells become less deformable.
Right, bystander effect.
This further compromises their passage through those partially obstructed capillaries and venules, and also shortens their survival, exacerbating the overall damage and contributing to anemia.
In stark contrast to P. falciparum, in the other human malarias, P. vivax, P. ovale, and P. malaria, this dangerous sequestration simply does not occur. As a result, all stages of the parasite's development are evident on peripheral blood smears, providing a more accurate picture of the parasitic load.
So what you see is closer to what you get.
Generally, yes. Furthermore, P. vivax and P. ovale exhibit a marked predilection for young red blood cells, and P. malariae for old cells, which limits their parasite density in the blood, seldom allowing it to exceed 2%. Conversely, P. falciparum's ability to invade red blood cells of all ages means it can be associated with very high and dangerously high parasite densities. It's crucial to note that P. knowlesi can also lead to dangerously high parasite densities due to its notably shorter 24-hour asexual life cycle, leading to rapid and dramatic increases in parasite load that can be just as dangerous as falciparum. Initially, the host responds to a malaria infection by activating nonspecific defense mechanisms. The spleen, a crucial organ for immunity and filtration, significantly augments its functions, accelerating the removal of both parasitized and uninfected red blood cells from circulation.
The spleen working overtime.
Absolutely. The spleen also performs a remarkable process called pitting, where it literally removes damaged ring-form parasites from within the red blood cell and returns the once infected cells back into the circulation, though their survival is shortened.
Wow, like cleaning them up.
In a way, yes. Those parasitized cells that manage to escape splenic removal are eventually destroyed when the schizonts within them rupture. And when that happens, the material released triggers widespread monocyte and macrophage activation, leading to the release of powerful pro-inflammatory cytokines.
The fever trigger.
Exactly. These cytokines are precisely what cause the characteristic fever and many other pathologic effects we see in malaria. Interestingly, temperatures of 40 degrees C, 104 degrees R or higher, can actually damage mature parasites. In untreated infections, this fever effect helps to synchronize the parasitic cycle, eventually producing those classic regular fever spikes and rigors, quotidian, tertian, or quartan, that historically characterize different malarias. However, with prompt and effective anti-malarial treatment today, these distinct fever patterns are seldom observed, a sign of effective modern medicine.
Here's where it gets really interesting. Our own genetics can provide a fascinating defense against severe malaria.
Natural selection in action.
Right, the geographic distributions of certain inherited blood disorders like thalassemias, sickle cell disease, hemoglobin C and E, hereditary ovulocytosis, and glucose 6-phosphate dehydrogenase (G6PD) deficiency very closely resemble the historical distribution of P. falciparum malaria before control measures were introduced. This is no coincidence. It strongly suggests these genetic traits confer significant protection against severe falciparum malaria. It's a powerful example of natural selection at work.
Absolutely. Take, for instance, HbAs heterozygotes who carry the sickle cell trait. They have a remarkable six-fold reduction in the risk of dying from severe falciparum malaria, and they're also protected from the bacterial infections that often complicate malaria.
It's fold.
Yes. The mechanisms are complex and fascinating. Hemoglobin S containing red blood cells impair parasite growth, especially at low oxygen tensions within the capillaries. Furthermore, P. falciparum infected red blood cells containing hemoglobin S or C exhibit reduced cytoadherence due to a reduced surface presentation of the adhesin PFE-MP1, which, as we discussed, is crucial for sequestration. So the parasite literally can't stick as well.
And the protection isn't limited to sickle cell. In HbAE heterozygotes, parasite multiplication is reduced at high parasitemia, which appears to shield them against severe disease. In Melanesian ovulocytosis, the red blood cells themselves are more rigid, making them intrinsically resistant to merozoite invasion, and the internal environment of the red blood cell is inherently hostile to the parasite's growth.
G6PD deficiency also plays a significant role, offering some protection against severe P. falciparum infections. However, its protective effect is even much stronger against P. vivax infections, highlighting the highly nuanced and specific interaction between host genetics and different Plasmodium species. It's a testament to the intricate coevolution between humans and these parasites.
So once the initial non-specific host defense mechanisms get the infection's rapid expansion under some control, it's followed by a specific immune response that works to manage the infection. The idea is that over time, repeated exposure to enough different strains of the parasite eventually confers protection against high-level parasitemia and overt disease.
But critically, not against infection itself.
Right, that's the key distinction. You can still get infected, but you won't get as sick.
This leads to a state called premunition, which is essentially a state of infection without illness. As a result, asymptomatic parasitemia is very common among adults and older children living in regions with stable and intense transmission, like hollow or hyperendemic areas, and even in some parts of low transmission areas.
Silent carriers.
Exactly. In these asymptomatic infections, parasite densities can fluctuate, but often average around 5,000 parasites per microliter of blood. While this is typically just below the level detectable by standard microscopy, it's certainly enough to generate transmissible densities of gametocytes, allowing the cycle to continue silently. This premunition immunity is mainly specific to both this species and the particular strain of the infecting malarial parasite. Both humoral immunity, involving antibodies, and cellular immunity, involving T cells, are necessary for protection, but the precise mechanisms are still incompletely understood.
Still some mysteries there.
Oh, yes. In immune individuals, there's a general increase in serum levels of IgM, IgG, and IgA antibodies, though it's important to note that much of this antibody isn't directly related to protection. Antibodies targeting a variety of parasite antigens are presumed to work in concert to limit the parasite's replication within the body. In P. falciparum infections, the variant surface adhesin PFE-MP1, our grappling hook protein, is considered the most important of these target antigens, as antibodies against it can block sequestration.
And here's a fascinating and crucial point related to immunity. The passive transfer of maternal antibodies actually contributes to a partial protection of infants from severe malaria during their first few months of life.
A vital window of protection.
It is a transient but vital shield. However, this complex immunity to the disease isn't permanent. It tends to decline if a person lives outside an endemic area for several months or longer, highlighting the need for continuous exposure to maintain protection.
Developing robust cellular immunity to malaria is notoriously difficult, hampered by several significant factors. Firstly, infected red blood cells lack major histocompatibility antigens on their surface, which prevents direct T-cell recognition, a fundamental mechanism for many immune responses.
So T cells can't see them easily.
Exactly. Secondly, there's often a degree of malaria antigen-specific immune unresponsiveness, where the immune system simply doesn't react as strongly as one might expect.
Adding to this complexity is the enormous strain diversity of malarial parasites. coupled with their sophisticated ability to express variant immunodominant antigens on the erythrocyte surface. These antigens can literally change during the course of a single infection, like a parasite constantly changing its disguise, allowing it to evade the host's immune defenses.
A master of evasion. This means parasites can persist in the blood for months or even years. In the case of P. malaria, they can persist for decades if treatment isn't administered.
Decades, wow.
All these factors, the complexity of the immune response, the sophistication of parasite evasion mechanisms, and the lack of a reliable in vitro correlate with clinical immunity, have significantly slowed progress toward developing an effective malaria vaccine. It's a truly formidable opponent for the human immune system and vaccine developers alike.
So imagine you're in a tropical country and you develop a fever. Malaria absolutely has to be on your radar. It's a common cause, but here's a critical point to engrave in your mind. Diagnosing malaria clinically, just by symptoms alone, is notoriously unreliable.
Cannot stress that enough.
You simply cannot rely on a hunch.
That's absolutely right. The initial symptoms are typically nonspecific, making it a master of disguise. We're talking about a general lack of a sense of well-being, headache, fatigue, abdominal discomfort, and muscle aches, all followed by a fever.
Sounds like the flu.
Exactly. These symptoms are remarkably similar to what you'd experience with a minor viral illness, which is why it's so tricky to identify without proper testing.
And to make it even more deceptive, sometimes certain symptoms become incredibly prominent. A severe headache, chest pain, abdominal pain, a cough, joint pain, muscle aches, or even diarrhea. These can be so intense that they misleadingly suggest another diagnosis entirely, sending clinicians down the wrong path.
To differentiate, while headaches and malaria can be severe, you won't typically see the neck stiffness and sensitivity to light or photophobia associated with meningitis.
Okay, good differentiator.
Muscle pain or myalgia can be prominent, but is generally not as severe as in dengue fever, and unlike in leptospirosis or typhus, the muscles won't be tender to the touch. Nausea, vomiting, and orthostatic hypotension, a sudden drop in blood pressure when standing up, are also quite common.
Now, you might have heard about the classic malarial paroxysms, those distinct fever spikes, chills, and rigors occurring at regular, predictable intervals, like every 48 or 72 hours.
The textbook picture.
Right. But here's a surprising fact. These are actually quite unusual today, thanks to prompt treatment. When they are seen at presentation, they often suggest an infection or a relapse with PVVAX or P. oval, rather than the more dangerous falciparum.
Initially, the fever in malaria is usually irregular, and in key falciparum malaria, it may never become regular at all. Non-immune individuals and young children often experience very high temperatures, soaring above 40 degrees C, 104 degrees air wrong, often accompanied by a rapid heart rate and sometimes even delirium. When it comes to seizures, childhood febrile convulsions can occur with any form of malaria, but generalized seizures are specifically associated with P. falciparum malaria and can be an ominous sign, potentially heralding the development of encephalopathy, known as cerebral malaria, which is a medical emergency. When examining patients with acute malaria, most with uncomplicated infections actually present with very few abnormal physical findings beyond the fever, general malaise, mild anemia, and, in some cases, a palpable spleen.
Relatively few signs, though.
For uncomplicated cases, yes. For non-immune individuals with acute malaria, the spleen typically takes several days to become palpable after the onset of symptoms. However, chronic, significant splenic enlargement is very common in malaria endemic areas, reflecting repeated infections over time and the spleen working overtime.
We also often see a slight enlargement of the liver, particularly in young children, which is also a sign of the body reacting to the infection. Mild jaundice yellowing of the skin or eyes is also common among adults, developing even in otherwise uncomplicated malaria, and usually resolving over 1 to 3 weeks. Importantly, malaria is not associated with rash, and those tiny red spots from bleeding called petechial hemorrhages, hallmarks of viral hemorrhagic fevers and leptospirosis, developed only very rarely in severe P. falciparum malaria. Their absence can be a crucial diagnostic differentiator, helping rule out other severe tropical diseases.
Now, let's talk about the stark reality of severe P. falciparum malaria. If uncomplicated falciparum malaria is treated appropriately and promptly, meaning the patient is still able to sit or stand unaided and can swallow medicines and food, the mortality rate is commendably low, less than 0.1%.
Okay, very treatable if caught early and uncomplicated.
Yes. However, the moment vital organ dysfunction occurs, or if the total proportion of infected red blood cells climbs to over 2%, which corresponds to more than 1 trillion parasites in an adult, the mortality risk rises steeply. This risk is, of course, highly dependent on the host's underlying immunity. This is where the disease becomes a true medical emergency.
And those specific manifestations of severe malaria, like cerebral malaria.
Among the most ominous manifestations of severe malaria is cerebral malaria, characterized by profound coma. Even with aggressive state-of-the-art treatment, coma is associated with significant death rates, approximately 20% in adults and 15% in children.
Still very high.
Extremely. Any degree of obtundation, delirium, or abnormal behavior in a patient with P. falciparum malaria must be taken very, very seriously, as it signals a critical brain involvement. The onset of coma can be gradual or sudden, often following a convulsion.
Cerebral malaria manifests as a diffuse, symmetric encephalopathy affecting the brain globally. What's interesting is that focal neurologic signs, meaning problems in a specific area, like a weakness on one side of the body, are actually quite unusual.
Right, it's more widespread dysfunction.
While there might be some passive resistance to head flexion, signs of meningeal irritation, like stiff neck, are typically absent. You might see subtle physical signs like divergent eyes, bruxism, teeth grinding, and a pout reflex. But other primitive reflexes are usually absent. Corneal reflexes are preserved unless the patient is in a very deep coma. Muscle tone and tendon reflexes can be variable, and plantar reflexes may be flexor or extensor. The abdominal and cremasteric reflexes, however, are absent. You may also observe flexor or extensor posturing, which are signs of brainstem dysfunction.
Routine examination of the back of the eye, or funduscopy, reveals important clues. About 15% of patients will have retinal hemorrhages, a figure that increases to 30–40% with pupillary dilation and specialized indirect ophthalmoscopy.
So looking in the eye is key.
Very key. Other notable funduscopic abnormalities include discrete spots of retinal opacification in 30–60% of cases, papilledema, swelling of the optic disc, in 8% of children, though rare in adults, cotton wool spots in less than 5%, and occasional decolorization of a retinal vessel or segment of a vessel. These are all critical signs of microvascular compromise in the brain, essentially showing the sequestration in action.
Convulsions are a common and serious complication, usually generalized and often repeated. They occur in about 10% of adults and up to 50% of children with cerebral malaria.
Half of children, wow.
Yes. Beyond overt, obvious seizures, more covert seizure activity is common, particularly among children, manifesting as subtle, repetitive tonic-clonic eye movements or even excessive salivation. This quiet seizure activity can be easily missed if not specifically looked for.
The neurologic sequelae, the long-term brain damage, are a significant concern, especially in children. While adults rarely experience them, less than 3% of cases, approximately 10% of children who survive cerebral malaria, especially those who presented with hypoglycemia, severe anemia, repeated seizures, and deep coma, will have residual neurologic deficits when they regain consciousness.
That's a heavy toll.
It is. These can range from hemiplegia, paralysis on one side of the body, cerebral palsy, cortical blindness, and deafness, to impaired cognition. The good news is that the majority of these deficits improve markedly or resolve completely within 6 months as the brain heals. However, for some other deficits, like persistent language problems, the prevalence actually increases over time, affecting about 10% of children. There can also be longer-term impacts on learning, planning, executive functions, attention, memory, and nonverbal functioning. The incidence of epilepsy is also increased, and tragically, life expectancy is decreased among these children who survive the most severe forms of the disease. Hypoglycemia, or dangerously low blood sugar, is another extremely important and common complication of severe malaria. It carries a poor prognosis and is particularly problematic in children and pregnant women who have higher metabolic demands.
Why does it happen?
It's multifactorial, resulting from both a failure of the liver to produce glucose through gluconeogenesis and an increased consumption of glucose by the host, and to a lesser extent by the parasite itself. A crucial contributing factor, especially historically, is quinine, which is a powerful stimulant of pancreatic insulin secretion.
The treatment itself can cause it.
Yes, hyperinsulinemic hypoglycemia specifically is a troublesome issue in pregnant women who are receiving quinine treatment.
And making it even more dangerous, the usual physical signs of hypoglycemia, like sweating, goose flesh, or tachycardia, are often absent in severe malaria, masking this critical complication.
So it's hidden.
Exactly. This makes clinical diagnosis incredibly difficult. What's more, the neurological impairment caused by the low blood sugar cannot be distinguished from the neurological damage caused by malaria itself, further obscuring the clinical picture and demanding vigilant blood glucose monitoring.
Acidosis, resulting from the accumulation of organic acids, is identified as a significant cause of death from severe malaria. In adults, this is often compounded by coexisting renal impairment. Hyperlactatemia, which is elevated lactic acid in the blood, commonly occurs alongside hypoglycemia.
Double trouble.
Indeed. In children, ketoacidosis can also contribute. Other organic acids like hydroxyphenolactic acid, ihydroxybutyric acid, and bull-hydroxybutyric acid concentrations are elevated, indicating widespread metabolic derangement.
Clinically, a key and very grim sign of acidosis is acidotic breathing, sometimes referred to as respiratory distress. This deep labored breathing is a grave sign of poor prognosis and is often followed by circulatory failure, which can be resistant to even aggressive fluid expansion or drugs that boost heart function. Ultimately, it can lead to respiratory arrest.
In terms of biochemical markers, plasma concentrations of bicarbonate or lactate are considered the best prognosticators in severe malaria, acting as an early warning system.
Something to watch closely.
Absolutely. It's important to note that hypervolemia, or low blood volume, is typically not a major contributor to this acidosis, distinguishing it from conditions like septic shock. The lactic acidosis itself is complex, caused by a combination of anaerobic glycolysis in the host tissues due to impaired oxygen delivery, impaired microcirculatory flow due to sequestered parasites blocking vessels, direct lactate production by the parasites, and a failure of the liver and kidneys to clear the lactate from the bloodstream. It's a perfect storm of metabolic dysfunction. Adults with severe P. falciparum malaria may also develop non-cardiogenic pulmonary edema, which is a dangerous form of acute respiratory distress syndrome, ARDS, sometimes even after several days of anti-malarial therapy, surprisingly.
Even after treatment starts.
Yes. The exact pathogenesis of this variant of ARDS is not fully understood, but it's linked to increased permeability of the tiny blood vessels in the lungs. The mortality rate for this complication is extremely high, exceeding 80%, making it one of the deadliest. Importantly, pulmonary edema can be triggered by overly vigorous administration of intravenous fluids, underscoring the delicate balance in fluid management for these patients.
Fluid management is critical then.
Absolutely crucial. It's worth noting that non-cardiogenic pulmonary edema can also develop in otherwise uncomplicated PVVAX malaria, though in those cases, recovery is usually the norm, highlighting species differences in severity.
Acute kidney injury is a common and serious complication in severe P. falciparum malaria. Its precise pathogenesis remains unclear, but it's believed to be related to erythrocyte sequestration and agglutination within the kidney's microvasculature, which can interfere with renal microcirculatory flow and metabolism, essentially starving the kidney of oxygen and nutrients.
Clinically and pathologically, this syndrome typically manifests as acute tubular necrosis, where the kidney tubules are damaged. Acute renal failure may occur simultaneously with other vital organ dysfunction, like cerebral malaria, in which case the mortality risk is very high. Alternatively, it might progress even as other disease manifestations begin to resolve, requiring continued vigilance. For survivors, urine flow generally resumes in a median of 4 days, and serum creatinine levels return to normal within an average of 17 days. Crucially, early dialysis or hemofiltration can significantly improve the chances of survival, particularly in cases of acute hypercatabolic renal failure. It's also important to note that oliguric renal failure, meaning very low urine output, is rare among children with malaria. Hematologic abnormalities, particularly anemia, are almost universal in malaria. Anemia, a hallmark of the disease, results from several factors: accelerated destruction of infected red blood cells, destruction of uninfected red blood cells due to immune mechanisms and reduced deformability, dyserythropoiesis, impaired red blood cell development in the bone marrow, and ineffective erythropoiesis.
Multiple causes for the anemia.
Yes, it's complex. In severe malaria, the deformability of both infected and uninfected red blood cells is significantly reduced, and the degree of this reduced deformability correlates directly with prognosis and the development of severe anemia. The spleen's clearance of all red blood cells is also markedly increased, further contributing to the blood loss.
For non-immune individuals and those in areas with unstable transmission, anemia can develop incredibly rapidly, often necessitating emergency blood transfusions. A hemoglobin level of 3 grams per deciliter or less on presentation is associated with increased mortality.
Very low.
Sometimes patients may experience acute hemolytic anemia with massive hemoglobinuria, a dramatic condition known as blackwater fever, where urine turns dark from hemoglobin released from scalized red blood cells. This can contribute significantly to renal injury.
Right, blackwater fever.
While some patients with blackwater fever have G6PD deficiency, in most cases, the exact cause of the massive hemolysis remains unclear. And in non-immune patients, a sudden onset of hemolysis can occur many days after artesunate treatment for very high parasite counts, usually due to the relatively synchronous loss of pitted red blood cells, those previously infected but cleared by the spleen.
Children in high transmission areas are typically anemic due to repeated malarial infections, stemming from both shortened survival of uninfected red blood cells and marked dyserythropoiesis. Anemia is also a common consequence of anti-malarial drug resistance, leading to repeated or persistent infection that slowly saps their blood.
Slight coagulation abnormalities are common in P. falciparum malaria, and mild thrombocytopenia, a reduction in platelet count, is usual. In fact, a normal platelet count should make you question a malaria diagnosis, as it's so commonly affected.
Interesting point.
Fewer than 5% of patients with severe malaria experience significant bleeding with evidence of disseminated intravascular coagulation, or DIC. Rare cases of hematemesis, or vomiting blood, from stress ulceration or acute gastric erosions may also occur, often signaling severe systemic stress.
Regarding liver dysfunction, mild hemolytic jaundice yellowing due to red blood cell breakdown is common in malaria. Severe jaundice, however, is primarily associated with P. falciparum infections, is more prevalent among adults than children, and results from a complex combination of hemolysis, direct hepatocyte injury, and cholestasis impaired bile flow.
So multiple liver issues contributing.
Yes. Critically, actual liver failure with loss of synthetic function does not occur in malaria, which distinguishes it from many other severe infections. However, when severe jaundice is accompanied by other vital organ dysfunction, often renal impairment, it carries a very poor prognosis. Hepatic dysfunction can also contribute to hypoglycemia, lactic acidosis, and impaired drug metabolism, creating a vicious cycle. On occasion, patients with P. falciparum malaria may develop deep jaundice, with hemolytic, hepatic, and cholestatic components, but without evidence of other vital organ dysfunction. In these specific cases, the prognosis is generally good, as the liver can recover.
In terms of other complications, it's important to recognize that individuals with HIV/AIDS and malnutrition are predisposed to more severe malaria, especially if they are non-immune due to their compromised immune status.
Concomitant bacteremia, a bacterial bloodstream infection occurring at the same time, is another serious concern. Approximately 6% of children diagnosed with severe malaria also have a bacterial bloodstream infection, significantly worsening their prognosis.
A dangerous combination.
Very. In adults, this proportion is generally lower, less than 1%, except in those with very high parasite counts, over 20% parasitemia where the risk increases. In areas of moderate and high malaria transmission, where many children are already carrying parasites, differentiating severe malaria from bacterial sepsis with incidental parasitemia is incredibly difficult.
Right? How do you tell what's causing the fever?
Exactly. Therefore, these children should ideally be treated with both antimalarials and broad-spectrum antibiotics, with activity against non-typhoidal Salmonella species from the outset. Empirical antibiotics should also be given to adults with greater than 20% parasitemia. And generally, antibiotics should be considered for severely ill patients of any age who are not responding to antimalarial treatment or who deteriorate unexpectedly, as a bacterial co-infection might be the culprit.
Other common infections that can arise include chest infections and catheter-induced urinary tract infections, particularly among patients who are unconscious for more than 3 days due to prolonged hospitalization and immobility.
Hospital-acquired risks.
Yes. Aspiration pneumonia, where stomach contents are inhaled into the lungs, can also follow generalized convulsions. The frequencies of these various severe P. falciparum malaria complications highlight the multi-organ impact of the disease. Before we delve into the general treatment strategies, let's briefly recap some unique and severe implications of malaria in special populations, particularly pregnant women and children. This underscores why specific treatment considerations are so vital for these vulnerable groups.
Absolutely. Malaria in early pregnancy is a significant cause of fetal loss, a tragic outcome. In high transmission areas, P. falciparum malaria in first-time or second-time pregnant women is associated with low birth weight, with an average reduction of about 170 grams, and consequently increased infant mortality rates. What's intriguing is that infected mothers in stable transmission areas often remain asymptomatic themselves, despite a very intense accumulation of parasitized red blood cells in the placental microcirculation, a silent yet dangerous process for the fetus.
And if you add HIV infection to the mix for pregnant women, it really exacerbates the problem. Maternal HIV predisposes pregnant women to more frequent and higher density malaria infections, and their newborns are then predisposed to congenital malarial infection, further compounding the problem and reducing birth weight. It's a devastating synergy of infections.
In areas with unstable malaria transmission, pregnant women are particularly prone to severe infections. They are especially likely to develop high P falciparum parasitemias, complicated by severe anemia, hypoglycemia, and acute pulmonary edema.
Very high risk.
Extremely. The outcomes for the fetus are often dire, including fetal distress, premature labor, and stillbirth or low birth weight, with fetal death being common in cases of severe maternal malaria. Congenital malaria, meaning the baby is born with the infection, occurs in less than 5% of newborns from infected mothers, and its frequency is directly related to the timing of maternal infection and the parasite density in the mother's blood and placenta.
It's not just falciparum that impacts pregnancy. P. vivax malaria also reduces birth weight by about 110 grams on average. But unlike falciparum, this effect is more pronounced in women who have had multiple pregnancies.
Interesting difference there.
And tragically, maternal death from hemorrhage at childbirth is also correlated with malaria-induced anemia, contributing to the high maternal mortality rates in low-income countries.
Turning to children, most of the more than 400,000 annual deaths from P. falciparum malaria occur in young African children. Common complications among children with severe malaria include convulsions, coma, hypoglycemia, metabolic acidosis, and severe anemia.
The big killers for kids.
Yes. However, deep jaundice, oliguric acute kidney injury, and acute pulmonary edema are relatively unusual in children compared to adults, highlighting some age-related differences in severe manifestations. Historically, severely anemic children presenting with labored deep breathing were often incorrectly attributed to anemic congestive cardiac failure, but it's now understood that this is usually caused by metabolic acidosis, sometimes compounded by hypovolemia. The good news is that, in general, children tolerate antimalarial drugs well and respond rapidly to treatment given appropriate care.
Malaria can also be transmitted in ways other than mosquito bites, reminding us of other vulnerabilities. We're talking about transfusion malaria, which can occur through contaminated blood transfusions, needle stick injuries, or shared syringes.
Right, bloodborne routes.
It can also be passed congenitally from an infected mother to her child.
And here's a key point related to transfusion malaria. In these cases, there are no relapses of PV vax and P oval infections.
Because no liver stage involved.
Precisely. Because the liver stages, or hypnozoites, those dormant forms we discussed, are bypassed entirely when the parasites are introduced directly into the bloodstream. While the clinical features and management of these cases are the same as for naturally acquired infections, primacaine is not needed for vivax or oval malaria transmitted this way because those liver stages, which primacaine targets, are never established. This is a crucial distinction for treatment protocols. Chronic or repeated malarial infections can lead to a condition called hypergammaglobulinemia, a type of anemia where red blood cells are normal in size and color, and in certain situations, massive splenomegaly or greatly enlarged spleen. This is part of what's termed hyperreactive malarial splenomegaly, or HMS.
HMS, okay.
Some residents of malaria-endemic areas in tropical countries exhibit an abnormal immunological response to these repeated infections. This is characterized by truly massive splenomegaly, hepatomegaly, enlarged liver, markedly elevated serum IgM antibodies and malarial antibody titers, an increase in lymphocytes in the liver sinusoids, and in Africa, an increase in B cells in the peripheral blood.
The underlying immunology of HMS is fascinating and complex. It's associated with the production of cytotoxic IgM antibodies that target certain T lymphocytes and an increase in the ratio of CD4 plus to CD8 plus T cells.
An immune system going haywire, basically.
Seems like it. These events can lead to uninhibited B cell production of IgM and the formation of cryoglobulins, which are IgM aggregates and immune complexes. This entire immunological process stimulates lymphoid hyperplasia and clearance activity, eventually producing the truly massive splenomegaly we observe.
Clinically, patients with HMS often present with an abdominal mass or a dragging sensation in the abdomen, sometimes with occasional sharp abdominal pains suggesting parasplenitis, which is inflammation around the spleen. They usually have anemia and some degree of pancytopenia, a reduction in all blood cell counts due to hypersplenism.
And parasites might not even show up.
That's the challenging part. Malaria parasites may not be found in peripheral blood smears by microscopy, making diagnosis difficult. Respiratory and skin infections are common, and tragically, many patients with HMS die of overwhelming sepsis as their immune system is dysregulated.
For those living in endemic areas, anti-malarial chemoprophylaxis is usually very effective in managing HMS, often leading to good results in reducing the spleen size. In non-endemic areas, specific antimalarial treatment is advised. There have been cases where HMS has been mistaken for hematologic malignancy, given the massive spleen and blood abnormalities.
Understandable confusion.
And disturbingly, in some cases refractory to therapy, clonal lymphoproliferation can develop, which may then evolve into a malignant lymphoproliferative disorder.
Another chronic complication is Cortin malarial nephropathy. This condition can arise from chronic or repeated infections with P. malaria and possibly other malarial species, leading to soluble immune complex injury to the renal glomeruli. This typically results in the nephrotic syndrome, characterized by significant protein loss in the urine.
Kidney damage from immune complexes.
Exactly. It's important to note that other unidentified factors must contribute to this process, as only a very small proportion of infected patients actually develop kidney disease.
On a microscopic level, the kidney damage, when examined histologically, shows focal or segmental glomerulonephritis, characterized by a distinctive splitting of the capillary basement membrane. Electron microscopy reveals subendothelial-dense deposits, and immunofluorescence studies confirm the presence of deposits of complement and immunoglobulins. Intriguingly, P. malariae antigens are often visible within these deposits, strongly implicating the parasite in the kidney damage.
Prognosis varies based on the pattern of these deposits. A coarse granular pattern of basement membrane immunofluorescent deposits, predominantly IgG3, with selective proteinuria tends to carry a better prognosis. In contrast, a fine granular, predominantly IgG2 pattern with non-selective proteinuria suggests a worse outcome. Cortin nephropathy is rarely reported nowadays and unfortunately usually responds poorly to treatment with either antimalarial agents or immunosuppressive drugs like glucocorticoids and cytotoxic drugs.
Finally, there's a compelling hypothesis linking malaria to certain cancers. It's possible that malaria-related immune dysregulation actually provokes infection with lymphoma viruses.
A dangerous interaction.
There's a strong association between childhood Burkitt's lymphoma, the Epstein-Barr virus or EBV, and areas of high transmission of P. falciparum.
The potential mechanism is that chronic P. falciparum malaria drives large numbers of EBV-infected cells through the lymph node germinal centers. This chronic stimulation and presence of the parasite can deregulate activation-induced cytidine deaminase, an enzyme involved in DNA modification. This deregulation can then lead to DNA damage, specific c-Myc translocations, and ultimately, sometimes, lymphoma. It's a sobering example of how a parasitic infection can interact with viral oncogenesis to contribute to cancer.
Let's talk diagnosis, because as we've repeatedly stressed, malaria cannot be diagnosed clinically with accuracy. It is famously unreliable.
The gold standard is seeing the parasite.
Right. The definitive diagnosis absolutely rests on the demonstration of the asexual forms of the parasite in stained peripheral blood smears. If reliable microscopy isn't immediately available, a rapid diagnostic test, or RDT, should be performed. It's a key principle. Don't just rely on symptoms alone, always confirm with a test.
To visually demonstrate the parasite, specialized stains are commonly used for blood smears. Romanowski stains, with Jamesa at a pH of 7.2 being preferred, are standard. Other stains like Fields, Wrights, or Leishman's can also be employed. For more rapid diagnosis, especially in patients with low-level parasitemia, staining parasites with the fluorescent dye acridine orange can be used. While it allows for rapid detection, it provides less information on species differentiation.
For malaria diagnosis, two main types of blood smears are used, each with distinct advantages and disadvantages. The thin blood smear is air-dried, fixed in anhydrous methanol to preserve cell morphology, then stained.
Preserves the red cells?
Right. The red blood cells in the tail of the film are examined under oil immersion. Parasitemia is expressed as the number of parasitized red blood cells per 1,000 red blood cells. Its advantages are that it's rapid, allows for precise species identification, is inexpensive, and in severe malaria, it can provide crucial prognostic information by showing the parasite forms. However, its main disadvantage is lower sensitivity, typically missing parasitemia below 0.05%. and P. vivax infected red blood cells can have an uneven distribution, making them harder to find.
The thick blood film is prepared with an uneven thickness, dried thoroughly, and stained without fixing, which causes the red blood cells to lyse.
Lyses the cells, concentrates the parasites.
Exactly. Because many layers of erythrocytes overlie one another and are lystos, the thick film has the significant advantage of concentrating the parasites by 40 to 100-fold compared to a thin film. This dramatically increases its diagnostic sensitivity, allowing detection of very low parasite numbers. Both parasites and white blood cells, WBCs, are counted, and the number of parasites per unit volume is calculated, typically by assuming a WBC count of 8,000 parler or using an actual patient count. A minimum of 200 WBCs should be counted.
But harder to read.
Yes, interpreting thick smears requires considerable experience due to common artifacts. And, importantly, 100-200 fields should be examined before a thick smear is definitively judged to be negative, making it labor-intensive.
This leads to a crucial nuance. In high transmission areas, partially immune individuals can tolerate up to 10,000 parasites per microliter of blood without showing any symptoms or signs of illness.
Asymptomatic carriage.
Right. So while detecting low-density parasitemia is sensitive in these regions, it actually has low specificity for identifying malaria as the cause of the illness. It's often an incidental finding when someone presents with fever from another condition, because asymptomatic parasitemia is so common in these populations.
This is where rapid diagnostic tests, or RDTs, have revolutionized field diagnosis. These are simple, sensitive, and specific antibody-based stick or card tests that detect specific malaria antigens in finger prick blood samples.
The dipstick tests.
Basically, yes. The most common RDTs detect P. falciparum specific histidine-rich protein 2, PFHRP2, or lactate dehydrogenase, or aldolase antigens. Some RDTs even carry a second antibody, either pan-malaria or P. vivax specific, allowing them to distinguish falciparum from the less dangerous malarias, which is critical for triage.
The advantages of RDTs are clear. They are robust, relatively inexpensive, and provide rapid results, often in minutes. Their sensitivity is similar to or slightly lower than thick films, around 0.001% parasitemia, making them excellent for screening. PFHRP2-based RDTs can remain positive for several weeks after an acute infection. This persistence can be a disadvantage in high transmission areas, where frequent infections lead to false positives for active disease, making it hard to tell if a current fever is new malaria. However, it can also be an advantage in diagnosing severe malaria in patients who have already taken antimalarial drugs and cleared peripheral parasitemia, but still have a strongly positive PFHRP2 test, indicating recent or ongoing heavy infection.
The disadvantages are also important to recognize. RDTs do not quantify parasitemia, which is critical for assessing severity, monitoring treatment response, and identifying treatment failure.
Can't get a number from them.
Right. Furthermore, the widespread use of PFHRP2 RDTs has put strong selective pressure on parasites, leading to an increasing prevalence of mutant strains that are no longer detected by current PFHRP2-based tests, a worrying example of parasite evolution in response to diagnostics.
Parasites adapting to our tests.
Indeed. Plasmodium LDH tests may miss low-level P. vivax, P. ovale, and P. malaria infections, and may not reliably speciate them, and they also have lower sensitivity for Pinolaceae, which may even be misidentified as P. falciparum.
The relationship between parasite density, how many parasites are in the blood, and prognosis, is complex and quite variable. Generally, patients with more than 100,000 parasites per microliter are at increased risk of dying.
But not always straightforward.
Right. Non-immune patients may die with much lower counts, while partially immune individuals can tolerate parasitemia levels many times higher with only minor symptoms, showing the huge impact of host immunity. In severe malaria, specific indicators on the blood film can point to a poor prognosis. A predominance of more mature P. falciparum parasites, meaning more than 20% of parasites with visible pigment, or the presence of phagocytosed malarial pigment in more than 5% of neutrophils, which is an indicator of recent heavy schizogony within the body.
An important point about gametocytemia. In P. falciparum infections, the peak of gametocytes typically occurs about a week after the peak of asexual parasite densities. Because the mature gametocytes of P. falciparum, unlike those of other Plasmodium species, are not affected by most antimalarial drugs, their persistence does not indicate drug resistance or a need for retreatment if a full course of appropriate therapy has been given.
So seeing gametocytes doesn't mean treatment failed.
Correct. They are simply the forms waiting to be taken up by the next mosquito.
Other diagnostic clues include phagocytosed malarial pigment seen inside peripheral blood monocytes. This can indicate a recent infection, even if parasites are no longer detectable, remaining evident for several days in films, or even longer in bone marrow aspirates, offering a retrospective hint.
Molecular diagnosis using polymerase chain reaction, or PCR, for amplifying parasite nucleic acid is even more sensitive than microscopy or RDTs for detecting malaria parasites and defining species.
PCR, the most sensitive.
Yes, but while currently impractical for routine clinical settings due to its complexity and cost, PCR is invaluable in reference centers and has proved extremely useful in epidemiologic surveys for identifying asymptomatic infections, especially as control and eradication programs drive parasite prevalences down to very low levels. Serologic diagnosis, using either indirect fluorescent antibody or ELISA, is useful for screening prospective blood donors and measuring transmission intensity in epidemiologic studies. But it has no place in the diagnosis of acute illness, as antibodies can persist long after an infection is cleared, giving a false sense of current infection. Let's quickly review the typical laboratory findings in acute malaria. A normochromic, normocytic anemia, where red blood cells are normal in size and color but simply fewer in number, is usually present.
Anemia is almost a given.
Pretty much. The white blood cell count is generally normal, although it may be elevated in very severe infections. You might see a slight increase in monocytes and a decrease in lymphocytes and eosinophils, followed by reactive increases in these cells in the weeks after the acute infection resolves. The platelet count is almost always reduced, typically around 100,000 per microliter, so a normal platelet count should strongly make you question the diagnosis of malaria.
Other common findings include an elevated erythrocyte sedimentation rate, increased plasma viscosity, and elevated levels of C-reactive protein and other acute phase proteins, all indicative of systemic inflammation. In severe infections, you'll see prolonged prothrombin and partial thromboplastin times, more severe thrombocytopenia, and even reduced antithrombin, the third levels, which can occur even in mild infection, indicating some degree of coagulopathy.
For biochemical findings in uncomplicated malaria, plasma concentrations of electrolytes, blood urea nitrogen, BUN, and creatinine are usually normal. However, in severe malaria, the picture changes dramatically. You'll likely find metabolic acidosis, low plasma concentrations of glucose, sodium bicarbonate, phosphate, and albumin, alongside elevations in lactate, BUN, creatinine, urate, muscle and liver enzymes, and both conjugated and unconjugated bilirubin.
A real metabolic mess.
It really is. Hypergammaglobulinemia is typical in individuals living in endemic areas due to repeated immune stimulation.
Urinalysis typically yields normal results. And in adults and children with cerebral malaria, a lumbar puncture will usually show a mean cerebrospinal fluid, CSF opening pressure of around 160 millimeter H2O. The CSF content is generally normal, or there might be a slight elevation of total protein, typically less than 1.0 GL, and a cell count of less than 20 cells per microliter. These are key for differentiating it from other causes of encephalopathy, which often show much higher cell counts and protein levels.
When it comes to the treatment of malaria, the general principle is clear and urgent. Patients with severe malaria, or those who are unable to take oral drugs due to vomiting or impaired consciousness, must receive parenteral antimalarial therapy immediately.
4V treatment right away for severe cases.
Absolutely. While antimalarial drug susceptibility testing can be performed, it's rarely available in real time, has poor predictive value for individual cases, and yields results too slowly to influence immediate treatment choices. Therefore, if there is any doubt about the resistance status of the infecting organism, it should be considered resistant, and treatment should proceed accordingly, giving the broadest effective therapy.
For uncomplicated P. falciparum malaria in endemic areas, artemisinin-based combination therapy, or ACT, is the first-line treatment.
ACTs are key now.
Yes. ACT is also the recommended first-line treatment for P. knowlesi infections, given their potential for rapid progression. For the other malarias, P. vivax, P. oval, and P. malaria, either chloroquine or an ACT is recommended. The specific choice of the ACT partner drug depends heavily on the likely sensitivity of the infecting parasites in that particular region. It's worth noting that ACTs are sometimes unavailable in temperate countries, limiting treatment options there for returning travelers.
Despite increasing evidence of chloroquine resistance in P. vivax from parts of Indonesia, Oceania, Eastern and Southern Asia, and Central and South America, chloroquine surprisingly remains an effective treatment for P. vivax malaria in many areas, and it remains universally effective for P. oval and P. malaria infections. This highlights the varied landscape of drug resistance globally.
But there's a truly alarming development that underscores the constant evolutionary battle. Artemisinin resistance in P. falciparum has emerged in Southeast Asia over the past decade.
A huge threat.
It is. This has been quickly followed by resistance to partner drugs like piperacine and mefloquine. As a result, ACTs are now failing in regions like Cambodia, Vietnam, and the border areas of Thailand. And very recently, there's clear evidence for the emergence of artemisinin resistance in East Africa, specifically in Rwanda and Uganda. This spread is a major global health concern, threatening our best line of defense.
Adding to this dire situation is the significant problem of falsified or substandard anti-malarial drugs, which are widely sold in many Asian and African countries. These poor quality medications with insufficient active ingredient may themselves be a cause of treatment failures, further complicating an already challenging therapeutic landscape and endangering patient lives.
Fake drugs are a massive problem. Severe P. falciparum malaria is unequivocally a medical emergency that demands intensive nursing care and extremely careful management in an intensive care setting. Frequent, diligent evaluation of the patient's condition is absolutely essential, minute by minute, hour by hour.
Constant vigilance.
Historically, quinine was the cornerstone of severe malaria treatment, but that's changed dramatically. In large, randomized controlled clinical trials, parenteral artesunate, which is a water-soluble artemisinin derivative, has demonstrated a significant reduction in severe P. falciparum malaria mortality rates, 35% lower in Asian adults and children, and 22.5% lower in African children when compared to quinine treatment.
Big improvement.
Huge. Therefore, artesunate is now definitively the drug of choice for all patients with severe malaria everywhere globally.
Artesunate can be given by intravenous injection, but it's also rapidly absorbed following intramuscular IM injection. In contrast, artemether and artemotil, which are oil-based IM formulations, are absorbed more erratically and do not confer the same survival benefit as artesunate, making them less ideal.
So artesunate therapy IM is preferred.
Yes. There's even a rectal formulation of artesunate that has been developed for community-based pre-referral treatment in rural tropical areas for patients who can't take oral medications. Pre-referral administration of rectal artesunate has actually been shown to decrease mortality rates among severely ill children without immediate access to parenteral treatment, buying critical time. Here in the U.S., artesunate has been approved by the FDA for emergency use and can be obtained through the CDC Drug Service.
It's worth noting that quinidine gluconate, an antiarrhythmic drug previously used to treat severe malaria in the United States due to its antimalarial properties, was discontinued from manufacturing in 2019, primarily because artesunate is demonstrably much more effective and safer.
Replaced by the better option.
Exactly. Although parenteral quinine is steadily being replaced by parenteral artesunate in endemic areas, it still retains a very limited role in the extremely rare cases of artemisinin-resistant severe P. falciparum malaria from Southeast Asia, where both artesunate and quinine are given together in full doses, pushing multiple drugs against the resistant parasite.
When managing severe malaria, adjunctive treatments, those given alongside the main anti-malarial, are a critical area where evidence has shown certain approaches to be either ineffective or even harmful.
Things not to do.
Precisely. These include high-dose glucocorticoids, urea, heparin, dextrin, dysferrioxamine, antibody to tumor necrosis factor, high-dose phenobarbital at 20 milligrams per kilogram, mannitol or large volume fluid or albumin boluses. It's imperative that these should not be used, as they have not improved outcomes in clinical trials and can, in some cases, cause more harm.
For specific complications, in cases of acute renal failure or severe metabolic acidosis, blood purification therapies like hemofiltration or hemodialysis should be initiated as early as possible.
Early dialysis helps.
Yes. These methods are more effective than peritoneal dialysis and are associated with lower mortality, directly helping to remove toxins and correct metabolic imbalances. If artesunate is unavailable and artemether or quinine must be used, an initial loading dose is absolutely essential to rapidly achieve therapeutic concentrations in the blood. Quinine, however, can cause dangerously low blood pressure if injected too quickly, so it must be administered very carefully by rate-controlled infusion only. If 5E access isn't possible, deep IM injections into the anterior thigh can be given.
The optimal therapeutic range for quinine in severe malaria isn't definitively known, but total plasma concentrations of 815 mg are generally effective without causing serious toxicity. It's important to remember that in severe malaria, the systemic clearance and apparent volume of distribution of quinine are markedly reduced and its plasma protein binding is increased.
So the drug behaves differently in sick patients.
Right. This means that for a given dose, blood concentrations will be higher, So, if the patient remains seriously ill or in acute renal failure for more than 2 days, maintenance doses of quinine should be reduced by 30–50% to prevent toxic accumulation of the drug. However, the initial loading dose should never be reduced, as that initial burst is critical to get drug levels up.
Convulsions must be treated promptly with intravenous or rectal benzodiazepines, a class of drugs that calms brain activity. The role of prophylactic anticonvulsants in children, giving them to prevent seizures before they happen, is still uncertain. If immediate respiratory support is not available, a full loading dose of phenobarbital at 20 milligrams per kilogram may be considered as a last resort to prevent further seizures.
Blood glucose levels must be measured frequently, every 4 to 6 hours, as hypoglycemia is a common and dangerous complication. All patients should receive a continuous infusion of dextrose, ideally maintaining blood concentrations above 4 millimoles per liter.
And keep the sugar up.
Yes. Hypoglycemia, defined as less than 2.2 millimole or 40 mg/dL, should be treated immediately with a bolus of glucose 20% dextrose, 2 millimole per kilogram over 10 minutes, followed by a continuous 10% dextrose infusion at 0.10 grams per kilogram per hour. Recurrent hypoglycemia is very common, particularly in patients receiving quinine, due to its insulin-stimulating effect.
The parasite count and hematocrit, a measure of red blood cell volume, should be measured every 6 to 12 hours, as anemia can develop very rapidly, often necessitating intervention.
Watching the blood counts closely.
There's some uncertainty about the exact thresholds for transfusion, with some evidence suggesting that moderate anemia might actually be beneficial in a patient with severe malaria and vital organ dysfunction, as it can reduce parasite load. However, the general recommendation is that if the hematocrit falls to less than 20%, whole blood, preferably fresh, or packed red blood cells should be transfused slowly, with careful attention to the patient's circulatory status to avoid fluid overload.
Careful transfusion.
In high transmission areas where blood for transfusion is in short supply, a 15% hematocrit threshold is widely used. Children presenting with very severe anemia hemoglobin, less than 4 grams per deciliter, and acidotic breathing require immediate blood transfusion, as this is a life-threatening combination. Accurate assessment of their circulatory status is vital to avoid complications.
Managing fluid balance in severe malaria is extremely difficult, especially in adults, due to the very thin line between overhydration, which can lead to life-threatening pulmonary edema, and underhydration, which can contribute to kidney impairment.
A real balancing act.
Absolutely. Unlike in many septic conditions, fluid boluses are potentially dangerous in severe malaria and should be approached with extreme caution, favoring cautious, slow infusions.
Nasogastric feeding through a tube placed into the stomach should also be delayed in non-intubated patients for 60 hours in adults and 36 hours in children to reduce the risk of aspiration pneumonia, which can be fatal.
Wait to feed until safer.
Right. As soon as the patient recovers sufficiently to take fluids by mouth, oral therapy with a full 3-day course of ACT should be substituted for the parenteral treatment. Importantly, merfloquine should be avoided as follow-on treatment for severe malaria due to an increased risk of the rare but serious post-malaria neurologic syndrome.
In areas with high co-transmission of both P. falciparum and P. vivax, such as the island of New Guinea, severe and potentially life-threatening anemia is common among children, with both species contributing significantly to the burden.
Both species causing severe anemia there.
Yes. Elsewhere, while severe P. vivax malaria can occur, it's generally uncommon. Many patients with severe malaria also have comorbidities, other underlying health conditions that contribute to vital organ dysfunction, further complicating their clinical picture and prognosis.
It's important to note that P. knowlesi can also cause severe disease, often associated with dangerously high parasite densities. Acute kidney injury, respiratory distress, and shock have all been described with P. knowlesi infections.
Knowlesi can be bad too.
However, unlike P. falciparum, cerebral malaria does not typically occur with P. knowlesi. Treatment for severe vivax and knowlesi malaria should follow the same aggressive recommendations given for falciparum malaria, reflecting their potential for rapid and severe illness.
For uncomplicated malaria, the treatment strategy depends on the Plasmodium species involved and the local drug resistance patterns. P. falciparum and P. knowlesi infections, given their propensity for high parasite densities and severe disease, should always be treated with an artemisinin-based combination therapy, or ACT.
ACTs for falciparum and knowlesi.
Always. For infections with sensitive strains of P. vivax, P. malaria, and P. ovale, either an ACT or oral chloroquine with a total dose of 25 milligrams of base per kilogram should be used.
ACT regimens are widely recommended because they are safe and highly effective across patient populations, including adults, children, and pregnant women. The rapidly eliminated artemisinin component, which could be artesunate, artemether, or dihydroartemisinin, is typically given for 3 days.
The fast-acting part.
Yes. This is paired with a more slowly eliminated antimalarial drug chosen based on the local sensitivity of P. falciparum in that specific area. The World Health Organization currently recommends 6 ACT regimens tailored to different regional resistance patterns.
In areas with low malaria transmission, a single dose of primaquine, 0.25 milligrams per kilogram, should be added to the ACT regimen. This serves as a P. falciparum gametocytocide, aimed at specifically killing the sexual forms of the parasite and thereby reducing the transmissibility of the infection from treated patients to mosquitoes.
Blocking transmission.
Exactly. This low dose of primaquine is considered safe even in individuals with G6PD deficiency, but it should not be given to pregnant women, as safety data is limited.
Ativaquinotogonol is another highly effective option globally, but it's seldom used in endemic areas due to its high cost and the propensity for rapid emergence of resistance, which makes it less sustainable for widespread public health use.
Cost and resistance limit its use there.
Also, patients treated with ativaquone tend to recover more slowly than those on an ACT, affecting patient experience.
A major global health concern and a testament to parasite evolution is the spread of artemisinin-resistant P. falciparum in the greater Mekong subregion of Southeast Asia. Infections with these resistant parasites are cleared slowly from the blood, with parasite clearance half-lives often exceeding 5 hours and total clearance times typically prolonged, leading to treatment failures. This is a critical threat to global malaria control.
For cases of recrudescence, meaning the return of parasites after initial treatment, second-line treatments are crucial. This might involve switching to a different ACT regimen or opting for a 7-day course of either artesunate or quinine combined with tetracycline, doxycycline, or clindamycin.
Have backup options.
Yes. It's important to note that tetracycline and doxycycline are generally not recommended for pregnant women or children under 8 years of age due to potential side effects like teeth discoloration, though the evidence for doxycycline's harm in these specific groups is considered weak.
Oral quinine, while effective, presents its own set of challenges. It is extremely bitter and regularly causes synconism, a collection of symptoms including tinnitus, ringing in the ears, high-tone deafness, nausea, vomiting, and dysphoria, a state of unease or generalized dissatisfaction.
Sounds unpleasant.
Very. Clinical responses to quinine are also slower compared to ACTs, and adherence can be poor, especially given the required 7-day regimens and unpleasant side effects.
When administering any oral antimalarial drug, patients should be monitored for vomiting for 1 hour afterwards. If vomiting occurs, the dose should be repeated to ensure they get the full medication.
Gotta make sure it stays down.
Right. Symptom-based treatment, like administering acetaminophen, can help lower fever and reduce the patient's propensity to vomit these drugs, thereby improving adherence and ensuring effective treatment.
Minor central nervous system reactions, such as nausea, dizziness, and sleep disturbances, are common with antimalarials, and usually mild. However, serious adverse neuropsychiatric reactions to mefloquine treatment, while rare overall, have a higher incidence of about 1 in 1,000 in Asia, and may be as high as 1 in 200 among Africans and white ethnic groups, requiring careful monitoring.
Mefloquine needs caution.
It does. All the antimalarial quinolines, chloroquine, imodiaquine, mefloquine, and quinine can exacerbate malaria-associated orthostatic hypotension, and generally, children tend to tolerate these drugs better than adults, though the underlying mechanisms for this difference are not fully clear.
It's important to know when to consider hospitalization. Pregnant women, young children, patients who are unable to tolerate oral therapy, and non-immune individuals, such as travelers, with suspected malaria should be evaluated very carefully, and hospitalization should be seriously considered to ensure rapid and effective treatment.
Low threshold for admission in high-risk groups.
Yes. And a critical diagnostic principle. If there's any doubt as to the identity of the infecting malarial species, treatment for P. falciparum malaria should be given immediately, because it's the deadliest form and time is of the essence.
While a negative blood smear read by an experienced microscopist makes malaria very unlikely, it doesn't completely rule it out. In such cases, thick blood films should be checked again 1 and 2 days later to definitively exclude the diagnosis, especially if clinical suspicion remains high.
Double check if unsure.
Always. To monitor treatment efficacy in non-immune patients, daily parasite counts should be performed until thick films are negative for asexual parasite stages. Drug resistance is likely if the level of parasitemia does not fall below 25% of the admission value within 72 hours, or if parasitemia has not cleared by 7 days, assuming assured adherence. In such cases, the treatment regimen should be immediately changed. To truly eradicate persistent liver stages and prevent relapse, a process known as radical treatment, primaquine should be given to patients with P. vivax or P. oval infection.
Targeting the hypnozoites.
Exactly. The recommended dose is 0.5 milligrams of base per kilogram once daily for 14 days in East Asia and Oceania, and 0.25 milligrams per kilogram elsewhere, reflecting regional variations in parasite sensitivity. Before prescribing primaquine, it is absolutely mandatory that laboratory tests for G6PD deficiency prove negative, as it can cause severe, life-threatening hemolysis in deficient individuals.
Critical G6PD testing first.
Non-negotiable. The same total dose can also be given over 7 days for convenience and better adherence. If the patient has a mild variant of G6PD deficiency, primaquine can be administered at a lower dose of 0.75 milligrams of base per kilogram, up to a maximum of 45 milligram once weekly for 8 weeks to mitigate the risk of hemolysis while still providing a curative effect.
For pregnant women with vivax or oval malaria, primaquine is strictly contraindicated due to safety concerns for the fetus. Instead, they should receive suppressive prophylaxis with chloroquine at 5 milligrams of base per kilogram per week until delivery, essentially suppressing the blood-stage parasites. After delivery, the radical treatment with primaquine can then be given safely.
A newer development in radical cure is tafenoquine, a slowly eliminated 8-aminoquinoline that has been registered in some countries. This drug offers the significant advantage of allowing radical cure to be administered in a single dose, greatly simplifying treatment and improving adherence.
Single-dose cure. That's promising.
It is, but significant caution is required due to the risk of protracted hemolysis in G6PD deficiency, including in female heterozygotes who may test as normal with current G6PD screens that only detect less than 30–40% of normal enzyme activity. Therefore, all patients must undergo a quantitative test of G6PD activity before receiving tafenoquine, and only those with greater than 70% of normal activity should receive the drug. It's also noted that its radical curative efficacy is lower than primaquine in Southeast Asia, indicating regional differences in parasite response. Let's delve into the detailed management of specific severe malaria complications, highlighting interventions that can significantly improve outcomes. For acute renal failure, if plasma BUN, blood urea nitrogen, or creatinine levels rise despite adequate rehydration, fluid administration should be immediately restricted to prevent dangerous volume overload.
Cut back fluids if kidneys fail.
Yes. As with other forms of hypercatabolic acute renal failure, renal replacement therapy, such as hemofiltration or hemodialysis, should be performed as early as possible. These methods are more effective than peritoneal dialysis and are associated with lower mortality, directly helping to remove toxins and correct metabolic imbalances. Many mild cases, however, can be managed conservatively if other indications for dialysis don't arise. Renal function usually improves within days, though full recovery may take weeks.
For acute pulmonary edema, or ARDS, which is caused by increased permeability of the tiny pulmonary capillaries, patients should be positioned with the head of the bed elevated at 45 degrees, given oxygen and intravenous diuretics to remove excess fluid.
Help them breathe, reduce fluid.
Right. Positive pressure ventilation, often requiring intubation, should be initiated early if immediate measures fail and oxygenation remains poor. In rare, severe cases, extracorporeal membrane oxygenation, or ECMO, where blood is oxygenated outside the body, may be required, essentially acting as an artificial lung.
Hypoglycemia management is crucial and requires vigilance. An initial slow injection of 20% dextrose, 2 millimol per kilogram over 10 minutes, should be administered immediately. This should then be followed by a continuous infusion of 10% dextrose at 0.10 grams per kilogram per hour.
Treat low sugar aggressively.
Yes. Blood glucose levels must be checked regularly thereafter, every few hours, as recurrent hypoglycemia is common, particularly in patients receiving quinine due to its stimulatory effect on insulin release. In severely ill patients, hypoglycemia frequently co-occurs with metabolic or lactic acidosis and carries a poor prognosis, making rapid correction essential.
Sepsis should always be suspected when any patient suddenly deteriorates for no obvious reason during antimalarial treatment, especially if hypoglycemia or a gram-negative septicemia are possibilities, as these can mimic or complicate malaria.
Think infection if things go south unexpectedly.
In malaria and endemic areas where a high proportion of children are already parasitemic, it is often impossible to confidently distinguish severe malaria from bacterial sepsis. Therefore, these children should ideally be treated with both antimalarials and broad-spectrum antibiotics, with activity against non-typhoidal Salmonella species from the outset. Empirical antibiotics should also be given to adults with greater than 20% parasitemia. And generally, antibiotics should be considered for severely ill patients of any age who are not responding to antimalarial treatment or who deteriorate unexpectedly, as a bacterial co-infection might be the underlying issue.
For other critical complications, patients who develop spontaneous bleeding should be given fresh blood transfusions and intravenous vitamin K to correct clotting deficiencies. Convulsions should be treated promptly with intravenous or rectal benzodiazepines, and, if necessary, respiratory support should be provided to ensure oxygenation.
Manage bleeding, seizures.
Aspiration pneumonia should be suspected in any unconscious patient with convulsions, particularly if they have persistent hyperventilation. In such cases, intravenous antimicrobial agents and oxygen should be administered, and pulmonary toilet should be undertaken to clear airways.
So we've talked about the intricate details of diagnosis and treatment on an individual level. But what about the broader global battle against malaria? The goal of global eradication of malaria remains a monumental, ambitious challenge.
A huge undertaking.
Success in this endeavor will absolutely require strong leadership, increased national commitment from affected countries, and substantial, sustained international support.
Indeed. The two main tools that have proven most effective in controlling malaria thus far are insecticide-treated bed nets, or ITNs, which have been shown to remarkably reduce all-cause mortality in African children by 20%, and artemisinin-based combination therapies, or ACTs, which we've discussed in detail.
Nets and ACTs, the big two.
They are our current frontline weapons, and new drugs are continuously in development, offering hope for the future.
And there's a truly significant development in the vaccine landscape: the RTS ACE01 vaccine. This vaccine, which provided 35–40% protection against P. falciparum malaria over 4 years of follow-up in African children, has recently been recommended by the WHO for widespread rollout.
A major milestone.
It is. This is a monumental step forward. The first licensed malaria vaccine. Even though its efficacy is still moderate, it's not a silver bullet, but it's a vital new tool.
Despite these advances, the challenges to malaria eradication are immense and multifaceted. They include the widespread distribution of Anopheles mosquito breeding sites, the enormous number of infected persons worldwide, many of them asymptomatic who act as reservoirs, and critically, the emergence and spread of resistance in P. falciparum to ACTs, threatening our best treatments.
Resistance is the big one.
Huge. We're also contending with increasing insecticide resistance and behavioral changes in Anopheles mosquito vectors, such as them starting to bite earlier or later to avoid ITN contact. And finally, inadequacies in human and material resources, infrastructure, and control programs in many regions remain significant barriers, creating an uphill battle.
To combat insecticide resistance, which is a growing problem, newer ITNs are being developed that combine pyrethroids with piperonyl butoxide. This ingenious addition actually increases mosquitoes' susceptibility to the pyrethroids by inhibiting the CYP-P450 enzymes that mosquitoes use to detoxify the insecticide, effectively disarming their defense mechanism.
Color chemistry.
Yeah.
It's also worth highlighting that eliminating P. vivax malaria is further complicated by the persistent challenge of lacking a simple, safe, and truly radical curative regimen that can effectively eradicate its dormant liver stages, those hypnozoids we talked about. Until we have a better way to tackle those hidden forms, vivax will remain a tough target for eradication.
To summarize malaria prevention strategies, the disease can be contained through a multi-pronged approach. The judicious use of insecticides to kill the mosquito vector, rapid diagnosis to identify and treat cases quickly, effective patient management, and where feasible, the administration of intermittent preventive treatments, seasonal malaria chemoprevention, or chemoprophylaxis to high-risk groups like pregnant women and young children.
A layered approach.
Exactly.
A newer strategy that's gaining traction is to safely accelerate focal elimination of P. falciparum by adding a single low dose of primaquine, which acts as a gamma-cytoside, to ACP treatment in areas that are actively working toward transmission reduction. This specifically targets the parasite stage that can be taken up by mosquitoes, thereby effectively breaking the transmission cycle from humans back to mosquitoes.
While there's immense research being poured into vaccine development, it's important to manage expectations. No safe, highly effective, long-lasting vaccine is likely to be generally available for widespread use in the very near future.
Still ways off for a perfect vaccine.
Seems so. The currently licensed recombinant protein sporozoid targeted adjuvanted vaccine, RTS S01, was only moderately efficacious in protecting African children in field trials, and unfortunately, its protection tends to wane rapidly. It's currently being deployed as a pilot project in Ghana, Kenya, and Malawi to evaluate its real-world impact. An irradiated live sporozoid vaccine is in late-stage development, and research continues for a vaccine to protect specifically against placental malaria, targeting a protein called VR2-CSA. While there's great promise on the more distant horizon, prevention and control measures will still rely heavily on anti-vector strategies and drug use for the foreseeable future.
Simple measures to reduce the frequency of bites by infected mosquitoes in malarious areas are incredibly important for individual protection. These include avoiding exposure during peak mosquito feeding times, which are usually dusk to dawn, and using insect repellents containing 10-35% ET.
D is still recommended.
Yes, or if DT is unacceptable, 7% picaridin is an effective alternative. Wearing suitable clothing that covers exposed skin, and using insecticide-treated bed nets or other insecticide-impregnated materials, particularly for sleeping, are also crucial. The widespread use of bed nets treated with residual pyrethroids has been shown to significantly reduce malaria incidence in areas where vectors primarily bite indoors at night.
And for travelers heading to malaria-endemic regions, chemoprophylaxis is a key preventative measure, and selecting the right one depends heavily on knowledge of local patterns of drug sensitivity.
Let's delve into the specifics of key chemoprophylaxis drugs. First, atovaquone-proguanil, widely known as Malarone.
Malaria, yeah.
This is the drug of choice for prophylaxis in areas with chloroquine or mefloquine-resistant P. falciparum. It's taken daily, starting 1-2 days before travel and continuing for 7 days after leaving the area. It's contraindicated in persons with severe renal impairment and not recommended for very young children, pregnant women, or breastfeeding infants under 5 kilograms. It should be taken with food or a milky drink for optimal absorption and is generally very well tolerated, effective against all malaria types, including multi-drug-resistant falciparum.
Then there's chloroquine phosphate, or Erelin. This drug is now only for very few areas with P. falciparum that is still sensitive to chloroquine, or areas with PVavax only.
Limited use now.
Very. It's a weekly dose, starting 1-2 weeks before travel and continuing for 4 weeks after. It can exacerbate psoriasis, but is generally well tolerated, though some may experience malaise, headache, visual symptoms from reversible keratopathy, GI intolerance, alopecia, or pruritus. Importantly, chloroquine is considered safe in pregnancy, making it an option for expectant mothers traveling to low-resistance areas. Chronic use for over 5 years can lead to dose-related retinopathy, though this is rare at the low prophylactic doses.
Doxycycline is another widely used option for prophylaxis in areas with chloroquine or mefloquine-resistant P. falciparum. It's a daily dose, starting 1-2 days before and continuing for 4 weeks after.
Daily doxy.
Right. It's generally contraindicated in children under 8 years and pregnant women due to concerns about tooth discoloration and bone development, though evidence of harm in these groups is sometimes lacking or debated. Generally is well tolerated, but can cause common side effects like vulvovaginal thrush, diarrhea, and photosensitivity, meaning increased sensitivity to sunlight.
Need sunscreen with that one. Hydroxychloroquine sulfate, or Plaquenil, is an alternative to chloroquine for primary prophylaxis, again only in those very few areas with chloroquine-sensitive P. falciparum or PVavax only. Similar to chloroquine, it's a weekly dose, starting 1-2 weeks before and continuing for 4 weeks after. It can also exacerbate psoriasis.
Mefloquine, known as Lariam, is used for prophylaxis in areas with chloroquine-resistant P. falciparum. It's a weekly dose, starting 1-2 weeks before and continuing for 4 weeks after. However, there are important contraindications. Persons allergic to mefloquine or related compounds like quinine or quinidine, and those with active or recent depression, generalized anxiety disorder, psychosis, schizophrenia, other major psychiatric disorders, or seizures.
Big psychiatric contraindication.
Yes, absolutely. It should be used with caution in persons with psychiatric disturbances or a history of depression. It's not recommended for persons with cardiac conduction abnormalities, although the evidence for significant cardiotoxicity is considered very weak.
Side effects from mefloquine at prophylactic doses are rare for severe issues like psychosis and seizures, though these are more frequent at higher treatment doses. More commonly, you might experience mild nausea, dizziness, fuzzy thinking, disturbed sleep patterns, vivid dreams, dysphoria, and general malaise.
Lariam dreams.
Right. However, confidence is increasing regarding its safety during pregnancy. Studies in Africa have found mefloquine prophylaxis to be both effective and safe during pregnancy. It's notable that mefloquine is often the only drug advised for pregnant women traveling to areas with drug-resistant malaria, generally considered safe in the second and third trimesters, with limited but reassuring data on first trimester exposure.
Next, primaquine, primarily for prevention of malaria in areas with mainly PVVAX. It's a daily dose taken with food starting 1-2 days before and continuing for 7 days after. Crucially, G6PD deficiency must be excluded before prescribing it, as it can cause severe hemolytic anemia.
Back to the G6PD check.
Always with primaquine. It's also contraindicated during pregnancy. Primaquine can also be used for presumptive anti-lapse therapy or terminal prophylaxis for PVVAX and P-oval infections with a 14-day course after departure for those with prolonged exposure, specifically targeting the liver hypnozoites.
The older drugs, like pyrimethamine and proguanil, which are dihydrofolate reductase inhibitors, were once widely administered, but rapid selection of resistance has significantly limited their widespread use today. Proguanil itself is safe and generally well tolerated, though mouth ulceration can occur in about 8% of users, and it is considered safe for prophylaxis during pregnancy.
But the combination.
Right. However, the prophylactic use of the combination of pyrimethamine and sulfadoxine is not recommended for weekly administration due to an unacceptable incidence of severe toxicity, including exfoliative dermatitis, skin rashes, granulocytosis hepatitis, and pulmonary eosinophilia. This combination has a high incidence of severe reactions, roughly 1 in 7,000, with fatal reactions occurring in 1 in 18,000 cases, making it too risky.
It's crucial to understand the difference in how these various antimalarial drugs act on the parasite's life cycle. Antimalarial quinolines, such as chloroquine, act only on the erythrocyte, or red blood cell, stage of parasitic development, meaning they treat the active infection but don't touch the liver forms.
Blood stage only.
Yes. In contrast, dihydrofolate reductase inhibitors, as well as atovaquone and primaquine, also inhibit pre-erythrocytic growth in the liver, providing what's known as causal prophylaxis. They prevent the infection from even getting into the red blood cells in the first place. They also demonstrate sporonticidal activity, meaning they inhibit parasite development in the mosquito, reducing transmission.
Because of the increasing spread and intensity of antimalarial drug resistance, the CDC now recommends that travelers and their healthcare providers carefully consider their destination, the type of travel, rural versus urban, and their current medications and individual health risks when choosing antimalarial chemoprophylaxis. It's no longer a one-size-fits-all approach.
We also need to issue a crucial warning. There's a growing problem of falsified and substandard antimalarial drugs, and indeed other medicines, found on pharmacy shelves in Southeast Asia and Sub-Saharan Africa.
The fake drug problem again.
It's huge. These poor quality medications with insufficient active ingredient or incorrect ingredients may themselves be a cause of treatment failures and can be deadly. Travelers should absolutely purchase their preventive drugs from a reputable source before going to a malarious country to ensure their efficacy and safety. For any prophylaxis failures or for malaria treatment consultation, resources like state and local health departments and the CDC Malaria Hotline, 770-488-7788, or CDC Emergency Operations Center, 770-488-7100, are available for expert guidance.
Beyond individual chemoprophylaxis for travelers, broader public health strategies are being implemented in endemic areas known as intermittent preventive treatment, or IPT, and seasonal malaria chemoprevention, or SMC. These are designed to protect large populations.
Let's break those down. IPT in pregnancy, or IPTP, involves giving treatment doses of sulfadoxine pyrimethamine at each antenatal visit, up to a maximum of once monthly during the second and third trimesters. The idea is to clear any parasites and prevent new infections in pregnant women.
Protecting moms and babies.
Exactly. A caution here. Women with HIV who are already taking trimethoprim sulfamethoxazole prophylaxis should not receive concomitant sulfadoxine pyrimethamine due to drug interactions. Dihydroartemisinin piperapine is currently being evaluated as an alternative.
Then there's IPT in infancy, or IPTI. This involves giving treatment doses of sulfadoxine pyrimethamine along with the routine immunizations included in the WHO's expanded program on immunization at 2, 3, and 9 months of life. It's an efficient way to deliver both vaccinations and malaria prevention to vulnerable infants.
Seasonal malaria chemoprevention, or SMC, involves giving monthly treatment doses of imodiaquine and sulfadoxine paramethamine to children aged between 3 and 59 months during the 3 to 4 month rainy season across the Sahel region of Africa, where malaria transmission is highly seasonal and intense.
Targeting the high-risk season.
Precisely. It's also important that children born to non-immune mothers in malaria endemic areas, typically expatriates, should receive prophylaxis from birth, as they lack maternal antibodies.
For travelers to a malaria endemic region, it's advised to start taking anti-malarial drugs 2 days to 2 weeks before departure. This crucial window allows for any untoward reactions to be detected before travel and ensures that therapeutic anti-malarial blood concentrations are present if and when any infections develop.
Start early.
Right. Anti-malarial prophylaxis should continue for 4 weeks after the traveler has left the endemic area, except for atovaquone-proguanil, or primaquine, which have significant activities against the liver stage of the infection, providing causal prophylaxis. These can be discontinued just 1 week after departure, a convenient advantage.
If suspected malaria develops while a traveler is abroad, obtaining a reliable diagnosis and anti-malarial treatment locally is the absolute top priority. Presumptive self-treatment for malaria with atovaquone-proguanil for 3 consecutive days, or one of the artemisinin-based combinations can be considered under special circumstances, particularly if immediate medical help is unavailable.
Emergency self-treatment.
Yes, but medical advice on self-treatment should be sought before departure from malaria endemic areas and as soon as possible after illness begins. Every effort should be made to confirm the diagnosis whenever possible, as treating blindly can delay correct diagnosis of other conditions.
Now let's shift gears slightly from malaria to another important protozoan disease that, while lesser known to many, is truly an emerging infectious disease gaining attention in North America. Babesiosis, right, caused by Babesia parasites. These invade and eventually lyse red blood cells, similar in some ways to malaria but transmitted differently. In the United States, most cases occur during the summer months and are caused by Babesia microti.
And spread by ticks. Yes, this particular species is typically found in small rodents and is transmitted by the deer tick Ixodes scapularis, the very same tick that transmits Lyme disease. The symptoms are often nonspecific and flu-like, which can make early diagnosis quite challenging.
When it comes to treatment, a single standard course of atovaquone plus azithromycin is often sufficient to achieve a cure for most immunocompetent individuals.
However, for highly immunocompromised patients, those with weakened immune systems, there's a significant risk of persistent infection and the development of antibiotic resistance, making treatment much more challenging.
So tougher for them.
Much tougher. These patients often require treatment for a longer duration than immunocompetent individuals. Additionally, for severe cases, an adjunct exchange transfusion where a patient's infected blood is replaced with healthy donor blood can be a useful intervention to rapidly reduce parasite load. In terms of prevention, in the absence of a vaccine and specific prophylaxis, the primary advice for persons at risk of severe babesiosis is to minimize their exposure to ticks and, if possible, avoid highly endemic areas altogether. Looking at the etiology, epidemiology, and modes of transmission more broadly, a few Babesia species have been implicated as causative agents of human babesiosis globally. These species utilize wild or domesticated mammals as reservoir hosts, such as rodents or cattle, and are maintained in their enzootic cycle by ticks. Humans are considered incidental dead-end hosts, meaning we're not part of the parasite's natural transmission cycle, we just get caught in the middle.
Accidental hosts.
Essentially. Most cases of human babesiosis are reported from across the northern hemisphere, but the predominant etiologic agent can vary by continent, reflecting local host tick ecosystems.
Focusing on the United States, B. microti is the etiologic agent for nearly all cases, accounting for about 95% of them. Most cases are reported from the Northeast and the upper Midwest, particularly from 7 specific states that form an endemic hotspot: Massachusetts, Rhode Island, Connecticut, New York, New Jersey, Minnesota, and Wisconsin.
The Lyme Belt overlap.
Exactly.
Woo!
This geographic concentration is largely driven by the distribution of the deer tick.
Beyond B. microti, other Babesia species seldom cause widespread disease in the United States, though they are present. However, symptomatic infection with Babesia duncani and B. duncani type organisms has been reported from Washington State, Oregon, and California, mainly on the West Coast.
West Coast variant.
And symptomatic infection with Babesia divergens-like organisms has been documented in Washington state, but also in the central states of Arkansas, Missouri, Michigan, and Kentucky, showing a broader but less common distribution.
Babesiosis has been a nationally notifiable disease in the U.S. since January 2011, meaning state health departments report cases weekly to the CDC, allowing for better tracking. In 2018, for example, a total of 2,161 cases were reported from 28 of the 40 states where babesiosis was notified.
I see more of it now.
Definitely. Looking back, in 2008, before national reporting, there were 624 cases in those 7 highly endemic states. A decade earlier, that number was just 230. This clearly shows a significant and concerning increasing incidence over time.
The increase in incidence is best explained by a greater density of ticks in highly endemic areas, as well as the steady expansion of the geographic range occupied by these ticks, likely due to climate change and environmental factors.
Ticks spreading.
Yes. It's interesting to compare it to Lyme disease. Although B. microti and Borrelia burgdorferi, the agent of Lyme disease, are both maintained in their enzootic life cycle by the same deer tick, Ixodes scapularis, the geographic expansion of babesiosis has actually lagged behind that of Lyme disease. This delay likely reflects the poorer ecologic fitness of B. microti compared to B. burgdorferi, and it's consistent with the observation that B. burgdorferi actually helps maintain B. microti in its enzootic cycle, showing a fascinating interplay between pathogens.
Other factors contributing to this rise include greater exposure of residents to ticks due to increasing forest fragmentation in suburban areas, creating more edge habitats where ticks thrive, and simply more time spent in leisure activities in grassy or wooded areas, increasing human exposure.
More time outdoors, more risk.
And to underscore how common this infection might be, seroprevalence studies looking for antibodies in blood have shown rates as high as 9% among residents of highly endemic states, particularly in areas with the highest disease incidence. Similar rates have even been noted among asymptomatic blood donors in these regions, indicating that babesiosis is likely underreported and/or that asymptomatic infection is far more common than is currently recognized. So what does this all mean for you, for global health, for our understanding of the unseen world? We've journeyed from the rare but devastating threat of Balamuthia mandrillaris and granulomatous amoebic encephalitis, a terrifying brain infection, and explored the intricate, globally impactful world of malaria.
Quite the journey.
We saw its complex life cycle, its remarkable ability to adapt, and the enduring challenges of diagnosis and treatment, from ancient fevers to the modern battle against drug resistance.
Yeah.
And finally, we touched on babesiosis, an emerging tick-borne illness with its own unique complexities, reminding us that new threats are always on the horizon.
If we connect this to the bigger picture, it profoundly underscores the continuous, dynamic battle we face against infectious diseases. Understanding their epidemiology, their intricate pathophysiology at a molecular level, and the nuances of their diagnosis and treatment are absolutely crucial to protecting global health. These aren't just isolated conditions, they represent a constant evolutionary dance between pathogen and host, where our scientific understanding is our greatest weapon.
We've explored the visible and invisible battles our bodies wage against these microscopic invaders, and the constant innovation required to fight them. What stands out to you as the most surprising insight into how a tiny parasite can reshape human history and health? And what does it tell us about our own resilience?
This raises an important question. As these pathogens continue to evolve and challenge our understanding, how might our deep comprehension of their biological mechanisms and our commitment to global health collaboration empower us to anticipate and overcome future infectious disease challenges, and perhaps one day turn the tide against these ancient enemies?